right, we'll call this meeting to order.
Oh, I
love that gavel. All right, Departmental County Public Hospital District number 1. Thank you all for coming. We'll start with the approval of the agenda. Has everyone had a chance to review the agenda? Any additions or changes to make to the agenda? Okay. Any other discussion? All right. Second. All right. That's all right. So, all right. So, all those in favor say aye.
Aye.
Okay. Consent agenda. The minutes. Hopefully, you've had a chance to review the minutes, the approval of checks, foundation report, finance committee minutes, and the quality council minutes. Any questions or anything to pull from the consent agenda?
Move for their adoption.
Okay. Second. Moved and seconded. Any discussion? All in favor say aye.
Aye.
Thank you. All right. First up then is a presentation from Amy Fuller, Credentialing County Public Health Department. The floor is yours. Thank you for coming.
I'm going to set the mood.
All right. No candles.
No. Some aromatherapy. Okay, I'll just kind of stand over here. So hoping that will okay. Yeah, I don't care about her. She's just my boss. Okay, so today I'm going to give you hopefully a brief and concise but very informative presentation on this community health improvement project that KBH, as well as many other community partners, are a part of. My name is Amy Fuller. I'm the assessment coordinator with the Credentialing County Public Health Department, and I've been chosen to share this information because myself with Robin have been helping to facilitate this process with our community partners. So I seem the appropriate choice to give an overview. So when we're talking, just real quick, you're going to hear this acronym, MAP, a lot, and MAP stands for Mobilizing Action Through Planning and Partnerships. So the word mobilizing, we're getting things moving forward. And action, what are we taking action on? We're taking action on population health. And not just any population, but the population of Credentialing County. So what health issues or overall quality of life issues are facing our community specifically? Residents that live here, people that were born here, what issues are we looking at to address collaboratively? And we chose the MAP framework, which was created by the CDC and the National Association of County and City Officials, NACHO, or NACHO, as I like to say, because everything is food for me. And it's a very specific framework, and when we say framework, we mean a set of activities that are evidence-based that result in a certain outcome. And what it looks like and why it's different from just a regular assessment where you're just taking a snapshot and pulling some numbers and reporting it to somebody is that, again, it asks you to do it collaboratively. So it's not just us as the health department, it's us with the hospital, the fire department, social service agencies. It's everybody coming together, and instead of working in our silos, coming together and saying, how can we pool our resources to address these issues instead of constantly fighting for the breadcrumbs of funding that we're all having to reach for. And so the first step in the framework is they say organize for success and partnership development. So it's a bit of that stakeholder analysis where we're saying who needs to be at the table, identifying those people and getting them to the table. And not just agencies, but community members and coalition advocates and members of faith-based organizations. Anyone that we interface with as the public health department needs to be at that table. And then we do a visioning exercise where we set our beliefs and our paradigm for moving forward. And then we do 4 very essential assessments. And so these arrows around the steps here, those are the 4 assessments that drive us forward. And the other acronyms you'll be hearing today are CHA and CHIP. So CHA stands for Community Health Assessment. I know in health we never hear acronyms. But CHA, Community Health Assessment, this is we're taking a baseline of our community. So, and the interesting thing about the MAP assessments is they don't just look at numbers, they also ask you to get the opinions of your partners, to get the opinions of your residents, and also to do assessments of the agencies that you're working with in providing the essential public health services. So you pull that information together, and what makes MAP different, again, is that it's strategic and forward thinking. So you're not just picking issues like diabetes or liver disease. You're picking strategic issues. So what are issues that are going to encompass a lot of different things and being forward thinking about it? And this will make more sense as I go forward. But So the 4 MAP assessments makes up our CHA, and from the CHA, we develop strategic issues, so those big forward-thinking issues, and then the goals and strategies that help us get those done. So the actions we need to take to make those happen is our CHIP. And again, we developed this as a community. And a really quick snapshot of how this came to be. So about in October 2016, KVH funded a grant writer to look at, there's a working group in town here called the A-Team, who is addressing super utilizers and care coordination. And it was a really great project. And KVH said, these guys need more funding for sustainability, so let's hire a grant writer. So they found a grant writer, and she found a grant that was more, again, strategic thinking, in that it said, let's form a rural health network. So you're not just supporting members of the A-Team, but also looking at the whole issue of care coordination or maybe healthcare access. So the Kittitas County Health Network was formed through a planning grant. So a planning grant was received for $100,000. And this network was formed. And as you can see, there's a lot of key agencies there that are working together. They formed a 501c3, so a nonprofit, again, with the idea that they're going to take a collective approach to health issues facing our community. Now, this little bubble here, we, Kittitas County Public Health Department, were chosen to facilitate this process because as part of our requirements, we need to do, again, that community temperature read every 3 to 5 years. We do community health assessments. So it's part of our requirements, and we did it in 2012 as part of a grant from the Robert Wood Johnson Foundation. And so we seemed the appropriate choice to implement this framework again. So the local public health system, I'll be talking about this, but I just wanted, again, to give kind of a visual representation that local public health, we're not operating in a silo. These are all the different organizations that we work with, either as grant partners or program partners, or just as part of coalitions. We partner with all of these different types of groups because all of these different groups play a role in the health of members of our community in some way, shape, or form. So what we did to initiate the MAP process is we got all our community partners together and we introduced them to the framework, and we created working groups to conduct the 4 assessments. Now, a little bit more about each of the assessments before I get to a brief overview of the results. The local public health system assessment is, again, where we look at the agencies, all the people, we like to call that the jelly bean diagram, what you just saw. Again, all food with me. But the jelly beans, how many of those jelly beans, when we work together, how well are we meeting the health needs of our community in all the different ways that we're supposed to as a public health department? There's a tool created by the CDC, which we get our partners together and we have them fill out a questionnaire and grade themselves in a lot of different aspects. So it's a very intensive tool. So that was its own assessment work group. The community themes and strengths assessment. So this assessment we did in partnership with the university, and this was an assessment of the community of resident opinion. So going out and doing verbal interviews, and we did an electronic survey, and we did assessment activities at the farmers market and in waiting rooms around town. I mean, just everywhere we could go. We blanketed the community with our questionnaires so we could really get a feel for what people that live here, what are their biggest health concerns? What do they think the strengths of living in this community are? Because when we're building solutions moving forward, we want to know where the community momentum is. We want to know where we will get backing from folks. So the forces of change assessment, this was combined residents and agency representatives. When we look at forces of change, we're looking at the events, trends, and various data that helps us create a snapshot of like what are the major incidents that have shaped our community and our community's health. What are the trends, such as population growth or the single events like healthcare legislation? What are those big things that can really change the trajectory of health in our community and that are specific to us, like closure of a mobile home park? What happens to those residents and then therefore happens to our community? Or the large presence of a university student population. That changes our health outcome snapshot. So really taking those things into account. And then last but certainly not least, if you're a data assessment person, you think in terms of quantitative and qualitative. This is your quantitative piece. So this is the hard data. So this is data from state, local. We have our own data that we got from different agencies, but then we also got it from state and national data banks. So and we get that through the Department of Health, Washington State Department of Health. So I'm going to just delve into the results, and I'm trying to, again, keep this relatively concise because this could be a very long presentation. But just a quick snapshot of Kittitas County. So one of the things that, when we're looking at the health of Kittitas County, that's going to impact us greatly in the next 10 to 20 years is the trajectory of population growth. So this is from a report that was commissioned by the county from Berks Analytics in Seattle, where they looked at all the factors that impact us, the university, the environment, building codes, things that would impact people moving to or moving away from our area. And this is the median trajectory. They're projecting about 2.8% population growth per year for the next 20 years. And already we're meeting that. So the population in 2016 was 42,000, give or take. But in 2017, it was already up to 44,000 was the census estimate. So we're seeing big jumps in population already. Now granted, a lot of this can be attributed to the university population. So here is just a little snapshot of our population. We're considered a young county because the median age is young. But as you can see, teenagers and then college-age folks. When you break down, I think last fall, the census of the Central Washington Ellensburg campus was about 13,000. It dropped to 10,000 in the winter, but still, it's a median, a little over 10,000. That's if our population is 44,000, and that's a quarter of our residents that are students, either grad or undergrad students. But then something else to take into account, especially when it comes to healthcare issues, is that our baby boomers are getting older and that we have a very large percentage of baby boomers. One of the things that may increase our population is we're being scoped out as a retirement destination. We're a but a bedroom community of Seattle. We have great recreation, and the cost of living isn't too high yet. So basic demographic, we are not an extremely diverse community, but that could be changing. With about 89% of us mostly white and 11% non-white. And the largest non-white minority is the Hispanic population. So in the details of the report, I hope everybody got a copy. If not, let me know. We talk more about some of the inequities with that population, that specifically the ones that are in Kittitas County that are experiencing maybe some access issues or disease incidence issues. Unemployment is the lowest.
Would you put that slide on
This,
the prior one just for 1 minute?
Yes.
I just want to take notes on it.
Oh, sure.
Thank you.
And again, this slide says by race alone because the census separates race and ethnicity, which drives me crazy. Besides for the fact that race is a social construct, it's very difficult to put it into, they separate the charts, so never mind, I won't go into it, I'm sorry. It drives me crazy.
That includes the student population?
Yes, it does, yeah.
How can that be?
I would say a lot of our diversity comes from our student population, actually.
Yes, pretty much.
Sorry, did I go too fast?
No, you're fine.
And I can send you these slides, too. Absolutely.
I'm puzzled why the student population is included. Many of these people, their primary residence is not.
I have a couple articles on that I can send you because when I was delving into these numbers, I was like, why are they counted as residents? It was, especially when, and I'll show you a little bit later, they really skew our income and our poverty data because they take their income data and incorporate it into our overall median.
I'd be real interested in this. Thank you.
And it's a standard way that the census is done. So, anywhere that has a university, when they do the census, they're going to count everybody who's living in that area at that time.
Let's say they're from Seattle, then they're not counted in Seattle.
No. They're counted here.
Bizarre.
Well, it's been 9 months.
And it's really difficult to separate. We've looked into, we can get info from the university to know how many students they have, but there's no data source that says, well, here's what you have for, non-student residents versus student residents.
And you can't write off all health issues of 18 to 24-year-olds, even though, what health issues do they have? So, Kittitas County snapshot, unemployment is lowest in 10 years. Largest employers are state and local government with, I think it's about 30% of all covered wages in this county are provided by state or local government. The top 5 job categories by occupations held, the first category, and this is all census reporting, sales, office, and admin support, management, business, and financial occupations, production, transportation, material moving, education and training and library, and then food service. Median income is lower than the state and the nation. Again, looking at that income data is skewed by student population. However, when you do break it down by household types, so they categorize householder by whether or not people are related, and there's still quite a disparity between families here that hold jobs, and if you look at, there are households with a bunch of people living together that aren't related, which are typically college students and roommates. You're still seeing a large disparity in those that are related in terms of incomes.
Is the discrepancy between Ellensburg and Kittitas County, is that due to Sancadia? Is that where that media is coming from that's higher for Kittitas County than it is for Ellensburg?
I would argue this low number is the student influence.
So it's just, I'm wondering, so if they're not in Ellensburg, then they're in the outskirts or Upper County or whatnot. So just by and large, people outside of Ellensburg have a higher income.
Students are dragging us down.
It's the motto here.
Dragging down the average.
But if you look at income by census block, you'll see, surprisingly, I mean, because our census blocks are huge, so like if you look at the one that covers Upper Kittitas County, it is higher, which I would guess is probably a lot due to Sancadia and a lot of bigger homes. There's a definition that this census looks at for permanent residency, and so I mean I would think some of those would be included, and I don't remember exactly what it is, but
I haven't seen anything that says that there's a lot of permanent residency up there, so we're mostly looking at incomes of folks living in Clay Elm and Roslyn proper. So when we're looking at, again, the specific population health outcomes of a community, this is based on death certificate data that was taken from the Washington State Department of Health. So life expectancy of a Kittitas County resident from birth currently is about 82 years. And just to give some perspective, there's a range in Washington, but Washington State residents tend to live a little bit longer than certain areas of the country, especially the rural South. I think the range is 76 to about 83 years, and I think the highest is San Juan and the lowest is Grays Harbor. But then I know there are certain counties in Tennessee where the age might be 68 or 67. So we're doing well.
Question there. I don't see any sort of substance abuse up here. Does it not make it?
Oh, it is up here. It's just, these are really broad categories. Sorry. It's in, so causes of death.
It's in accidents.
Oh, it's in accidents, right.
So
there
like overdose, for example.
Would be an accident.
Yes.
Would be,
okay.
Yeah.
Thank you.
Yes. And so the areas that are in red are the areas where we're higher than the state. And accidents, and I tell this story all the time, it's probably getting old, but I think, they include transport and non-transport. So again, car accidents, vehicular accidents, drug and alcohol overdose, but also, having lived in this county now for 10 years, we have a lot of do-it-yourselfers. Mm-hmm. And I like to tell the story. I've got two neighbors, both are retired vets, both guys. One guy has a very small house, but two very large workshops. Mm-hmm. And then where he's constantly working on cars or building things. And then my other neighbor, I always like to tell the story of, he likes to deal with his tree overgrowth problem by climbing up onto his roof and putting on a football helmet and waving a chainsaw around on a stick. So, well, it's like it's built that way, but still, when you're coming over work and you see this, you're just like, this cannot end well. But he's doing great. He's doing great. But, I think Kittitas County has a lot of do-it-yourselfers, so it just doesn't surprise me that we have a higher rate of accidents, physical accidents. This is a concerning one, as you know, especially in the media lately. Suicide is something we're seeing more of. And you do tend to hear about it more in rural counties. I've heard pieces lately, especially farming communities. Suicide has been on the rise.
Is that residents who die in the community as well, or?
Yes.
So if they're a resident but they passed away someplace else, that would not be included.
Well, that's a good question. Like if they have an accident here but are transported to Harborview and they passed away there,
where's their place of residence?
Are they because that would make Harborview really happy.
Yeah, I think it's their place of residence. So but I can, if we put it in notes, I can get back to you on that one. That is a good question, but I think it's based on place of residence. So morbidity, so when we talk about morbidity, the technical term for incidence of a disease in a population. Now, and I should have mentioned this before, these are all ages combined. These rankings change when you look at certain age groups. So, looking at children, younger children versus young adults and teenagers, and then older adults, and then definitely older adults above 65, this changes quite a bit. Some concerning stuff, injury and poisoning includes drug and alcohol overdose, and some concerning things that we've seen in terms of hospitalizations in the past, since we did this the last time, which is about 5 years ago, is the increase of injury and poisoning and mental illness as the number 2 and 3 reasons that young adults and teens are being hospitalized. And a lot of those are ER type related things, but again, just kind of a reflection of what we're seeing nationally. So health behaviors, we're basing this on the framework of the Robert Wood Johnson population health categories. The health behaviors, it's health behaviors, the physical environment. We also look at social and economic determinants and clinical factors. So I will go through those 4 factors, and again, these are just brief snippets of all the data we collected, but I thought these are some of the interesting highlights. So as a whole, as a county, we're smoking less than in previous years, which is great. We have seen a decrease in teen smoking, but an increase in vaping. So the vaping companies have been doing a great job of making it look fun and fruity and non-toxic. And again, with the Healthy Youth Survey, what we're seeing is that it's the beliefs around these things about whether or not they're harmful, normed by their peers and adults around them. So right now, it's not being perceived as dangerous. There isn't the same amount of money put into anti-vaping campaigns as there have been in anti-tobacco. 17% of adults report binge drinking, and that's about, I think it's 4 or more drinks in a 2-hour period for women, 5 or more for men. And they measure it by blood alcohol content. So it's, if you have a blood alcohol content of 0.08% in 2 hours, and binge drinkers don't tend to be alcoholics or have problems with alcohol, but as a country, we tend to be a country of binge drinkers. So we don't drink a lot, but when we do, look out. And so, and again, it's kind of interesting to see how similar those numbers are. If 17% of our adults are reporting this, and then you look at our teen data, and 18% of our, this is in 2016 data, 18% of our 10th graders are reporting problem or heavy drinking. And again, that's the amount of drinks in a certain time span within 30 days. STIs, so sexually transmitted infections, continue to increase at a fairly stark rate, and our trend lines have a lot in common with the Walla Walla, the county that Walla Walla is in, where they have Whitman College. So I don't think it's an accident that we're seeing high rates of STIs and we have a very large young population. We are active compared to the state and nation. We have a lot of people who walk or bike to work, and we have a lot of access to recreational opportunities, whether it be parks or gyms or, again, public spaces for recreation. But still, we are seeing concerning numbers of obesity, people who are obese and overweight. And again, this reflects national trends. But according to BMI reports, we have about 30% of our population that would be seen as obese, according to BMI, or 42% would be considered overweight. And in 2016, 68% of our 10th graders did not meet the minimum physical activity requirements. Lots of screen time.
How does that compare to, say,
The state?
local national statistics?
I'd have to put the bullet on that question. I don't have it right now.
Sorry, how we're comparing with our somewhat local numbers.
What I can do is in my follow-up notes, I'll send you a link to the Healthy Youth Survey. They have a really fun interactive website.
I love interactive.
I can tell. That's what I'm like. I bet you would like this. But where you can look at any single county or school district, and you can pull out that data. So they have really cool fact sheets that they'll print out for you that would have all of that. So
thank you.
I will send that link out with any follow-up materials or answers to questions. Clinical care factors. So we have seen, since the 2012 and the insurance legislation that passed, we have seen an increase in our insured population, and particularly those insured with Medicaid. But we still have higher rates of uninsured adults and children than the state. Not hugely higher, but slightly. We are known as a health provider shortage area by federal definition. And we, right now, so primary care physicians, it's about 1,570 residents to one provider. And mental health, it's about 710 to one. And dental, it's about 2,700 residents to one. And again, this data is probably about 1.5 to 2 years old, and it could be different by now. But it's the last time I checked, I think primary care was up to 1,600 residents, so they're not fluctuating that much. But again, with our population change, these numbers are going to change as well. And they determine this by looking at, when you are one of these providers, you have to have licensure, so they have databases to get the exact number of licensures per resident. Primary care, but that does not include RNs or physician's assistants or other people who could provide that. So that's something to take into account. We're seeing cancer screenings, so when we're looking at breast cancer, mammography, colon cancer, pap smears, so basic cancer screenings, we're seeing that we're equal to or above the state, but we've decreased overall over the past 5 years. And we also have seen an increase in preventable hospital stays, and this is by the Medicaid, Medicare definition, which usually it means an older individual, and it's related to ambulatory issues that have happened in the home, so slips, trips, and falls that are happening in the home that are very preventable, but very detrimental. Social and economic factors, if you've worked in health, I'm sure you've heard the terminology upstream determinants or upstream factors, where you're looking at when you're looking at health outcomes like death and disease, there are things that contribute very strongly to whether or not you'll see a prevalence of both. And so income and poverty and education are all, very tied to people's overall health outcomes. And so in our county, we've got about 23% of our families who meet the criteria for the poverty status. We are in the middle of what is considered a housing crisis, which means we don't have enough livable homes for those who need them, especially some of our more vulnerable populations. There's a large income disparity. According to county health rankings, we are second worst in the state. However, again, we're taking into account student income data here. So that's a very large discrepancy, but they get that ranking by comparing the top earners against the bottom earners and looking at that ratio. So, but again, we're still seeing disparities between incomes. So high school graduation rates are steady, so this is great because again, high school graduation, the higher you get in your educational journey, the higher your income usually is and the better your health outcomes are. And our graduation rates are steady at about 82%, and they've been there for about 10 years. Our community tends to be higher ed. We have a larger percentage of higher ed folks. Those who are 25 years and older, 40% of them have an associate's, and 33% of folks 25 years and older have bachelor's in our community, which is great. There is, again, though, when we're looking at that income gap in our particular community, roughly a $30,000 gap between someone with a high school diploma and someone who has a college degree if they're working in this county. Unemployment is decreasing, and it's currently at 6%. However, that is slightly higher than the state. Another area where we're not supporting our families very well is there's a licensed childcare shortage. So currently, and this is licensed childcare. This isn't talking about subsidized childcare, of which there's even less. It's about 4 kids per slot. So it's very competitive right now, and it's very expensive. Any family, I have several family friends that live in this county where someone has stayed home and opted not to work because it really was a wash between paycheck and childcare. So single parent households, about 1 in 4 of our households has a single parent, and they're up against a lot, and their health outcomes tend to be worse, and so do their kids because of lack of support and lack of basic resources. And our veteran population, about 9.6% of folks 18 and older are veterans, with the largest amount being Gulf War vets. And last of the 4 areas, the 4 factor areas, is our physical environment, again contributing to our overall health. Days of drought are increasing as our wildfire concerns, and this directly impacts our air quality, and which is bad for all of us, but especially sensitive populations such as little kids and older adults with respiratory issues. Our drinking water quality is good. We haven't had any infractions. Food safety infractions are low. Recreation access is very good. One thing that we could work on, improve on, is there's not enough public transportation, and we do have quite a few commuters. And of our commuters, about 30% of them, 25% of them spend 30 minutes or more behind the wheel. We actually have food access issues, which surprises a lot of people. Even though, our population centers are in Ellensburg and Roslyn, but there's not actually a lot of food access for those folks who live out of it. So if you're looking at residents per physical access space, we're actually not. There are still some access issues there. We also have a ton of fast food per residence. And when you're looking at families who are on the lower income spectrum, and you're looking at students, we have a lot of access to fast food and not a lot of healthy food options for those folks. A higher percentage of substandard housing units. We have lower alcohol and drug arrests and low violent crime and lower child abuse and neglect rates than we have had in previous years. I missed a point up there. Our housing cost burden, when you're talking about income, and about 39% of our households in this county pay over a third of their income or their household income to housing costs. And then the community strengths. So the next two slides are just going to be some basic summaries about what we went out into the community, and this is a very brief overview of what we found. Community strengths. So people who live here, they say, again, they live here because they like the recreation access. They like the fact that it's a good place to raise kids. And they feel that it's a safe community and it's a close-knit community, and they really like their neighbors and they feel like they can rely on their neighbors. Agencies that we worked with said that they appreciate that there's a fast response to crisis. It may not always be organized as well as it could be, but it's always fast and it's strong. There's a good enforcement of laws and regulations, and people work in partnership to enforce those. And agencies are really willing to collaborate with each other. So again, we could be doing it better, but there's a lot of momentum and will to do it. So that's great. And forces at work, again, this is double-edged sword, but there's growth and collaboration. We're a very resilient community, so we take our knocks, but we get up and we get back to work. And there's a lot of support for community health work, and we're a proactive community, so people like to get ahead of the problem. Community concerns. So the top concerns that people said were mental health and mental health services and mental health issues and not being enough support for issues. Poverty was a concern, substance abuse, and then housing. Agencies who work with people, lack of providers, need more integration to pool our resources together. Again, we're all working with limited resource sets, and better access to underserved populations, because again, when you remember that jelly bean diagram, the folks who are working with mental health aren't seeing all the patients, but law enforcement is, the emergency room is. There's overflow from the populations that aren't getting served. So we need to be working together to address their issues. And the forces at work that may work against us, again, population expanding, so growth can be good, but if the infrastructure isn't there to address it, sorry, then it can work against us. If there's limited funds and we're not talking to each other because we're all so invested in our own little silo, and poor communication can lead to a breakdown. So the local public health system, again, when I talked about public health, has these 10 key essential responsibilities that we have to any population that we serve, and in this case, it's Kittitas County. So we're monitoring their health, and this is, we're taking the temperature of our community. We're finding out what issues are impacting us. We're also here to diagnose and investigate possible outbreaks. We're here to inform and educate the people in our community about health issues, to mobilize community partnerships, develop policies to create sustainability. We're here to enforce laws to help access and link people to care, assure a competent workforce, and there mean that our public health workforce, so that speaks to our agency in particular. And then, of course, evaluation of services being provided. So all of these different essential services, and research is the 10th, I'm sorry. We got our partners together and we asked them, we're going through each of these 10 essential services. How well do you as an agency interact with us to meet these? And there's very specific core questions. So we use this tool by the CDC, and they gave themselves a grading. So do you do it not at all? Do you do it somewhat? And again, so keep in mind, this is a somewhat subjective tool. But we had a member from all of our jelly beans. And when at the end, we identified all the areas that we're not doing so great in. And then of those areas, we prioritize them by areas where we have low performance and where they're the highest priority. And the priority was set forth by what we agreed as a group, as a CHACHIP work group, what our priorities and our vision and our values were, but also what was set forth in the grant as being community health improvement priorities. And current state national trends, what needs to be at the top of our list. So what we found is that current technology that enhances communication and service delivery, evaluation of our population health. This needs to be a cyclical thing. We need to be doing this more often. And evaluation of our services that we're providing people. Personal health service needs, we need more of them. We need better linkage. And community partnerships. And that speaks specifically to the next step. So we've identified all of our results. What are we going to do with all that information? And what are we, and not just us, the health department, but what are we going to do with all of our partners to address this data that we found? So we sat down with all this data and we looked at it and we identified strategic issues. And remember, strategic issues are broad. Again, this isn't the specific, diabetes or suicide. This is a very broad question that's going to help guide our actions moving forward. So we looked at all that data and we looked at the various topics and we said, how serious is this threat to health? Are there immediate consequences of not addressing these things? How many people do the various issues affect? Will helping address one issue help address others? How important is the issue to the community? Are we going to have backing and momentum from both our partners and residents? And more importantly, how feasible is all this? So we can have a real pie-in-the-sky idea of what we want to do, but how feasible is it actually to achieve these goals? So looking at all the different issues, we pulled them together and came up with 3 overarching strategic questions. How can we improve the delivery of current community resources and healthcare services? How can we address social and upstream factors to improve health outcomes in our community? And how can we adequately sustain collaborative community health improvement efforts and increase cross-sector communication? And these are very high-level thoughts, very high-level questions that need specific answers. So how do we turn that into action? Well, this comes back to we're mobilizing action through planning and partnerships. Okay, so here we have our strategic issue, which is the big overarching question. And then our goal is going to be the long-term aim. What is this going to look like in 5 years if we're making progress on our strategic issues? And then our strategies are the very specific actions or interventions or evidence-based practices that are going to get us there. So for example, if our strategic issue is how can we improve the delivery of current community resources and healthcare services, our goals will be people get all and only the services, care, and resources they need in the most efficient manner. And 2, care is provided in a manner that overcomes organizational boundaries. Now, again, those are broad, but this is what we want it to look like in 5 years. Our strategies are going to be really specific things. Now, we haven't exactly crystallized these yet. These were just some of the ideas that were brought forth in our planning stages. But, a strategy would be increasing enrollment assistance, improving our shared technology hub when it comes to exchanging health information, which there's already, even in the time while we've been planning this, there's already been a lot of movement forward in the community in terms of electronic information management and exchange. Yay, sir. I know it's still... You say that loud. It always takes 3 times as long to adjust to a new system as they say it's going to. It'll be good.
Yeah.
Increasing ratio of services to patients, adopting programs for care coordination. So maybe community health workers, however you choose to deliver those services, but really getting behind an evidence-based program. And where we're at right now. So we are due to publish the CHIP tomorrow. So the CHIP is going to be all of the strategies that we are going to use as a collective agency under the umbrella of the Kittitas County Health Network moving forward to move the dial on some of those health issues. Again, one of the strategic issues is strengthening our collaborative infrastructure because, we're stumbling forward, but we're trying to do it strategically and we're trying to do it together. So we're not working against each other, we want to work with each other. And right now we are putting the plan into place and strengthening our infrastructure to deliver these strategies. That was not as concise as I was hoping for, but got a lot of information.
Question.
Yes.
Once you publish, Chip, Will it be a format like this that is a take-home format, or is it online printed out format?
That's a question for you guys. These beautiful documents were paid for by KVH by donation because they had a grant that was
Not by donation, by
by grant. Sorry, Julie. Yes, sorry. It's never free money. Yes, never free money. Yes, it is a very specific itemized cost that was part of a grant of some sort. I believe. A flex grant. Thank you. So yes, it wasn't just given, but it was in that sense a donation to our cause. So I don't know if there's any money left in this cost.
It's very nice and easy to read and absorb. So I will be pouring over this and coming to
Thank you.
And it will look similar, I mean, because there's an electronic version of that as well. And I mean, we can print out, I mean, we have a nice color printer at the health department. So we'll have printed copies, they just won't be nice and bound like this.
And shiny.
And what are your distribution sites for these? How many do you have?
Basically, we were going to give one to every community partner that was at the table because we only had 50 beautifully bound copies. The rest we're giving out electronically. So basically saying share with, we can print out if people like them, but most people who actually would sit down and read this will do it electronically.
So we can access it at the website.
Oh yes, definitely.
Starting
Yes.
tomorrow, you said?
The community health assessment is already on our website. So when you go to the Kittitas County Public website, there's a section that says reports and plans. And that's where the current community health assessment is, and that's where the plan will be posted. We have a grant deliverable tomorrow for the planning grant to get that in. We probably won't publish it or post it for possibly another week because we kind of ran behind on our timeline a little bit, so we want to give a chance to our participants and our community partners to take one final look at it and kind of provide any final edits to that before we actually publish it. So it might be another week or so before we get the actual CHIP document out there.
It's really exciting.
Other questions or comments?
I had a question. When you look, how user-friendly is the data? Can we look at Upper County? Can we get into the data and really stratify it if there's an initiative around the students and look at what their comorbidities are and things?
So I sourced all the data in the back, and it's all, anybody could access it. There's a few things like the hospitalization data and the death data you'd have to request from the health department, but the rest of it is accessible online, and I got it actually through a website called Community Commons, where they look at tract-based information and data. However, because we're such a small population, the data can be skewed sometimes, so it's touch and go whether you want to use it. Certain points are great, solid pieces of data, and other are kind of throwaways, just because the census blocks are so large.
The smaller we break down our data in our county, because we have such a small county, so the more you want to stratify it by race and ethnicity or by location, the less accurate, and you see much more fluctuation from year to year just because of our small numbers. So just something to consider. We've already heard from several community partners that have used it for, grant applications or other kind of planning purposes, which is what it's intended to be. It's intended to be something that can be used community-wide. Thank you.
Other questions, comments? Okay, thank you very much.
Thank you.
I assume that if we have questions that come to us as we read it, just email them to you, right?
Yeah, I was just going to say, if you had any questions or want to be part of the process, because we're always recruiting people if you're invested, because there's a lot of topics under those strategies, like care coordination. If you have passion for anything, then just let us know, and we'd love to have you on board. So.
Thank you.
Don't forget your flash drive. That's what I was
Okay,
saying.
now it's time for public comments. If you have a public comment, please state your name and your address. Please try to keep your comment to 3 minutes if possible. Is there anyone here who would like to make a public comment?
This just occurred to me. This is kind of a tag along, but I'll make it as a public comment. So, Robin Reed, Public Health Administrator. What do you need my address?
Address.
1301 North Main Street in Ellensburg. I just wanted to thank KVH for their support in this project. I mean, obviously we had a lot of people participating in this, a lot of different agencies, but KVH was really an outstanding partner in just helping with some of the things that we at the health department didn't really have the funds or capacity to do, just helping with supplies, doing in-kind space. Amy Diaz, who was the KBH representative, attended the most meetings of any of our participants. I believe she only missed one in an entire year.
She gets an award.
Yeah, definitely. So just want to thank you for all your support in this. KBH was definitely a very important partner. So
Thank you.
thank you.
Any other public comments? All right, thank you. Thanks a lot. Okay, now to reports and dashboards. I'm going to spring something at you guys. So, while you give your reports, please just keep in mind we've all read them, so you don't have to go into too much detail. Also, if there's some specific question or issue that you need us to address as a board, just let us know. Just help us focus. I see that we have motion in a couple of these things, but if there are things that we need to vote on or otherwise, but if there's some specific guidance that you need, just let us know. Them? Yeah, them, right? Those, the people we're going to report to. Yeah. So if they have specific questions that they would like us to address, or specific issues that we need to, does that address anything that you?
Administrative team.
I guess that just seemed weird. I didn't get the context in which it was.
The context is a board member has said we get too much reportage, so
Oh, yes, yes.
I was going to direct them to
I get
specific.
you, I get you.
Right?
I figured
Anyway,
I'm the one who made that comment. And coming off our meeting at Chelan and going to some of the sessions on how to be a more effective board, one thing that was made, a point that was made really emphatically at every one of those was reduce the amount of time that you listen to reports. Have those submitted in writing. Read them carefully before the meeting. If you have questions or if you want someone to expound upon something that they made in the report, do that. But the board meeting should facilitate important strategic discussion among board members. And on my experience, having been on the board for 20 years, is that most of the time is just sitting here and listening. And it isn't in any way to disrespect the good work you do, and it is important that we hear it and be reminded of it. But we also need to step up our game a little bit, do more discussion of issues. We just come back from the meeting at Chelan where a number of very salient issues in healthcare delivery and medicine were thoroughly presented to us. And I think we need to sometimes talk about those more extensively. So I was the one that made that comment. And again, it's not to disrespect or in any way reduce the importance of the work that people in our senior leadership team do. But it is to say we as a group probably ought to be more proactive in generating discussion and take on that burden more ourselves.
So in the spirit of discussion, and I agree this discussion is important, it's extremely redundant. I think that over the past year there has been a new model format of presenting ideas and reporting, which I think is going quite well, and I think it's incumbent upon us to voice our interests or concerns or questions in order to facilitate that discussion that we desire.
I agree, but the number of minutes that is taken up by the reporting is about, on average, about 15 more than it used to be under the old format.
Is it due to questions and interaction?
No, it's just due to presentation and listening. And again, well, let's just work on it and see what we can do. I think it's our responsibility as board members, though, to be more proactive and more take the bull by the horns, as it were, and get to some of these questions. But we tend sometimes, I think, to be kind of passive and just listen. And that isn't. It may be that certain questions simply don't arise from the reports we hear, so we don't ask them.
For the record, I'd like to say that I think we've had 6 minutes of discussion so far.
about this. That's good. That's good.
Well, let me just try. What I was trying to do was to walk a tightrope here, because what I think that since this is a public meeting and there are often people who haven't read the board packet prior to coming here. I mean, there are some people in the audience maybe. That I don't have a problem with the brief summary, and I think that the current format with the larger, with a lot more information that we can focus on specifically, with sort of bullet points about things that we should pay particular attention to. I like that format. And what I was trying to do was to allow that, right? That would sort of generate discussion, but also maybe to guide discussion if there's specific questions that they have for us, or obviously if things need to be voted on. But I was thinking that might satisfy everybody, but apparently not. Anyway, so let's
Matt,
just.
can I just
go ahead. Roy.
Point on I'll bail you out.
Hey,
I mean, my experience in the 5 months I've been commissioner is that there's a lot of sort of fertile discussion that takes place in committees, and we typically have 2 commissioners per committee, and so it seems to me some of those substantive issues emerge during the discussion of those committees. Now, granted, they may not make it all the way here to the full board meeting, but I think they do get reflected in some of the agenda items, and how do we proceed from there. So, I mean, I have found those committee meetings being quite interesting, and an opportunity to raise questions that you wouldn't normally bring up here. And the staff has been very receptive to comments that are being made, and it's been a real learning experience. Pardon me? Yeah, 2 years. Yeah.
Anyway, so don't feel the need to change anything this time, but in the future maybe just think about whether there might be a question or an issue that you want us to address specifically. We're open to sort of leading questions, guiding us towards something specific that you would like board feedback on. The current format where you call our attention to specific elements of it, it seems like at least there's some feeling that that's good. So maybe just to add on to it to address this issue about discussion, if there are specific issues you'd like to call in the future. But don't feel obligated to do it now, because I just sprung it on you.
Come on, Mandy.
No pressure. I had nothing to add.
All right.
I know. So.
Well, in that case,
the
we
one
talk
time.
about. All right. So.
Questions.
Right, there we go. All right. Now our first report from Andy Olson.
Yes.
Quality improvement. Have at it.
It's a lot of pressure.
I'm going to be timing it.
Yeah, I don't, unless there's questions or concerns, I don't have anything to add.
Well, we haven't had a patient start in a while. Is one coming up soon, or there just haven't been? I recommended one to you that one about the person who had breast cancer, was diagnosed with breast cancer, but it was because of the fine quality of the new mammogram, the digital mammogram. It had been missed. It had been there for a while, but it had been missed before. And he was really, really grateful.
I remember you mentioning that, but I don't.
I think I mentioned
a lot of
it
times I
in
pass stories
Gala.
on to Michelle, but I may not have gotten the patient information.
I'll give it to you because I think that is really an affirmation of.
So a lot of times we've been using our safe packages as our patient stories, and it's not time for a new round of them yet.
I was one of the challenges we had a couple of years ago, I think, and I call attention to this frequently, is sepsis and surgical site infections. We've been very good at that stuff for a long time, and I think that's a great sort of story of improvement that we've had. It's nice to see that sepsis anyway is up 100% with the protocol.
I would like to call out, and I know that's highlighted here, family birthplace metrics and satisfaction. fantastic. I'm not surprised, anyways, but that's really great. I had a question on the satisfaction dashboard, and I don't think that this is going to change just by the nature of the small n sample. It just looks so very volatile, and is that just to be expected? That's probably.
Which one in particular?
Oh,
Or are you talking about all of them?
all of the
Some of them-
zigzagging ones.
The what?
All of the zigzagging up and down quite a bit, like cardiopulmonary.
Well-
We raised this at the QI Council. It's exactly the same as med-surg.
It
Still.
is actually. Yeah, it's it's a,
Yeah, okay, really?
Wait, what's the same as what?
well, if you look at the lines, they look identical between med-surg and cardiology.
So you confirm that
I did not confirm that yet,
Okay.
but the data on the bottom,
some of us were
It's
wondering whether
different.
that was just a copy of
Wow.
the graph.
Gosh, you guys are really good at listening.
Yeah, so, sorry Erica, did you want to expand on that?
No, I guess there shouldn't be an expectation that it'll ever look any smoother than that because of our small sample size. Like the.
I wouldn't say that.
It might
mean,
smooth out over time.
I would hope so. What it means is there's a lot of variation in the responses we're getting, but it's also, you have to remember, it's a percentile rank. So it matters what other people are doing compared to us.
Right.
I'm looking forward to what our data will look like with Cascading, where we can actually compare ourselves to multiple peer groups. So we might be able to have a better perspective about how we're doing compared to maybe rural hospitals or so.
How soon does that come online?
July 1st is when the contract change happens. The first data file won't be able to be sent though until the week of July 9th. So the discharges from July 1st going forward. I don't think we'll really have a decent amount of data to look at until into August.
All right.
So August would really be the soonest that I would have something I think worth sharing here.
Well, that'll be interesting.
I'm really curious to see, and because this particular dashboard is the percentile rank, there are some places where when you have a larger group of people to compare yourself to, maybe we do really well here compared to the nation, and we'll look a lot better, but maybe we'll look really crummy. I'm not sure. It's going to be interesting to see.
Can I go back to your point about family workplace?
Oh, yeah.
Mandy and I have an appointment to sit down and talk about how we can really celebrate that with our staff. We literally can't get better than that. So they are those patient perception skills are as high as they can get. So we have to figure out a way to advance that.
And it wasn't on here, it's not on here yet, but I did get a chance to pull rehab data because rehab and the clinics just started with the same survey system before, but I just looked at that with Marcus the other day and they only had 12 respondents, but they were at the 99th percentile too in every single question except for one. So,
How many questions?
I can't remember the number of questions.
7.
Yeah, it's like 9 questions.
Okay.
Still, the sort of top box 9s and 10s for every single question. I'm really excited for when we're all in one system. We can really look at this. It'll be kind of hard to compare it to the previous because there will be different methods that we have surveyed in the past, and so that's the only thing. I'm not sure how much we'll want to compare it.
Might be a little
That
apples and
over
oranges.
time. What?
Will it be a little apples and oranges?
That's
Moving.
yeah, and it's different peer groups.
Sure.
So I'm not sure we'll want to put them on the same
Okay.
dashboard.
Thank you.
Other questions from Andy about the quality? Okay, thank you, Andy.
Very well done, thank you.
All right, good. All right. CEO reports.
So I would like to introduce Cheyenne. She's over there trying to somehow make minutes out of the conversation happening there. So. And also Ron Erlacher, I don't know if you've met him before, but he's the new director of facilities. So from now on, that's who you blame on our bids. And I am going to violate some of the rules here, I think. But we were all just at this land conference, and I am on the board of Association of Washington Public Hospital District. And I wanted to highlight just a couple things that came up at the board meeting. We are working with Foster Pepper and entertaining some legislation to see if we can't fix that pet issue with. So usually that takes more than one cycle, but AWPHD, the ESCs, the school systems all recognize that that's a mess. So maybe we need to fix on that. And also the day of the meeting, Supreme Court decision about compulsory participation in unions or collective bargaining agreements for public employees came down. That's something that we're working on as well with AWPHD. And then I am also on the Washington State Hospital Association Rural Committee, and I just wanted to mention that there's some new activity around statewide EMS services, and I think that Rhonda represents us on the current activity that we have. But we think there's something else kind of afoot there. Kittitas County, because we have one fire-based EMS service through KDFR, and we have one hospital or non-traditional type EMS service up in Hospital District 2, I think makes a really good representative to that for that rural question. So EMS is very much focused on fire, very much suburban, urban. So we're going to try to get the right people here into the table to make sure that we're well represented. And again, both fire and Kittitas County so those were my CEO committees and boards. I do have, I'd like to update you on DSHS and have your conceptual approval for how we go forward with that lease and map. And I think we all participated in a series of conversations, email conversations about some of the roadblocks we were hitting on that lease. And just to remind you, there's a little over 18,000 square feet in the MAP, or the Medical Arts Center, that's under the lease of the Department of Social and Health Services. Even prior to our purchasing that building, we were working with the previous owner to notify DSHS and the state that that lease, when it terminated, August 31st, 2018, we had no intention of renewing it. That is the space we want to move our person to. As soon as we purchased that building, we engaged in that conversation again. So I feel like we've been very diligent. We've also been a little mystified that we haven't heard more activity, seen more activity around their relocation. So we were not entirely surprised when we got sort of a panicked communication from the state that they were not going to be able to make that date. We went out of our way to extend a couple of options to them, including Radio Hills, some temporary space, and Mountain View 309, some temporary space. I am really pleased, I think, with where we came down. The DSHS reached out to our attorney, I think it was just yesterday, and what they would like to do is take us up on our initial offer, which is allowing them to stay through December 31st, 2018. So they would do some partial vacations in the fourth quarter. So again, their lease ends August 31st. If we can allow them to stay through December 31st, they're confident that they'll be able to relocate at that point. The issues we will be negotiating are access beginning September 1st, so that we can begin scoping that area, doing our planning, getting our architects in there. That's a very secure area because of the population they serve, but we need to be able to get in there in that fourth quarter and start doing our planning. So again, the end date that they're looking for is December 31st. On January 1, it is going to start costing them significant dollars if they're not out of there. I'm thinking $20,000 a week penalty if they're not out of the state.
There was some talk too, wasn't there, because of the delay of them helping DSHS helping to cover some of the costs of but what it's going to cost us extra since they're going to be taking that space when we want to renovate.
Right, so what I did is I sat down and I looked at what they were saying is we'll vacate the 2 smaller spaces, but they were talking about lingering quite a bit longer in the 3rd floor. So I took the cost per square foot and tried to extrapolate if we had to start, bid construction twice, bring subs in twice, bring materials in twice for delay, and I came up with a significant number. We're a little off of that model at this point. If they can get out by December 31st, and we can have the entire space, I think we're in a better position than we would have been otherwise.
Could they identify a replacement space?
So they're building 2 buildings to be newly constructed. And the first one, they're convinced they will have what they call some sort of occupancy, beneficial occupancy by December 15th. So 2 buildings are going up. They feel like they can, by the end of the year, have their first occupancy.
All the folks.
Yes, they'll vacate entirely. So it's about action.
I was just going to say, this is so important since we are experience services and having places to put. Erica, I can't hear you, I'm sorry. Oh, just say that this is so important because we're expanding services and we have providers coming online and more accepting more patients. We need real estate to carry out these activities. And, I'm also concerned about any more delays and how that might affect the cost of construction and improvement moving forward. So hopefully,
We know we're definitely in a escalating inflation environment right now, so I find it is worrisome. The other thing we need to do as we move forward, so penalties if they're not out, access to the entirety of the space, and we may need to limit access to the elevator if we can get into that 1st and 2nd floor, if we make the decision to vacate or to demolish that existing small elevator that they have, then they may not be able to use it. And then also, we have incurred real legal costs, and I'd like to be reimbursed for those, because Richard's done a lot of work on our behalf. So those are, I guess the initial statement is I think that, again, our patients and their clients overlap a lot. We recognize that they provide a valuable service to the underserved in this community, so we've been trying to work with more people since the services when we get with those 4 caveats about access and cost.
Question, would we be seeking through legal action reimbursement by the state of Washington for our legal expenses?
Yes, that would be part of our in exchange for us agreeing to extend the lease 4 months. That would be part of it. And I'd also just like to call out, this has been between an attorney in Seattle and attorneys in Olympia. The folks here on the ground at DSHS have just been trying to do the work. And so this is an entirely separate state agency that deals with real estate.
thank you for calling that out.
So any objections to proceeding around those principles?
So, how much is this going to push back renovation?
Probably.
Is it
4
going to push
months.
it back 4 months?
4
So
months.
it won't be able to be ramped up. It will be ramped up and sort of won't be as bad as if the whole building were taken over for 4 months. We'll be able to get started on some things.
So at senior leadership today, talking to some of the team members, Ron and Dr. Martin and Carrie Barr, the expectation is we will use that time to be shovel ready on January 1. So that's what we're looking at.
Okay, so it won't necessarily be a 4-month delay over what it would have been otherwise, but there will be some kind of
Are there going to be some communications to the community about MAC 1 and what's going to happen, and the SHS will be vacating, and in anticipation of any negative press that may emerge?
So can I ask you to listen to Michelle's presentation about states and see if you still have those questions?
I certainly can do
She
that.
has an entire
But I will say that the way that this has been worked out and the compromise that we've come up, that they've come up with, it's. I mean, I think that even though no one is thrilled with it, I think that everyone's happy.
It had
enough.
the potential to be a lot worse.
Yeah.
Right.
So
That's,
I mean, no one's getting everything they want, but I think people are happy enough with it on both sides.
Thank you.
So I don't think it'll be. We can talk about that later.
Yeah.
But I think that this compromise is good for everyone.
Agreed.
yeah.
When do we expect that floors 1 and 2 will be available to us?
I don't know the answer.
Not sure.
I need to pull the trigger with Richard and get him working on the contracts with the state. So,
And that's not all you need is sort of a consensus.
yeah,
About
as long as you're okay with those principles, I'll move.
Are there
Do
any?
you need a motion on that?
No, it's just
okay.
it's just a general sort of feel for the board. But are there any objections or concerns with this that anyone has? Everyone's okay with their moving forward? Okay.
Now, I do need a motion. In your packet is the results of the bid on MAC 1, which, as you recall, was about 2,160 square feet. It's the Sheldon space on the first floor. And we anticipate, and also at your place, I put the construction schedule. So we had, I believe, asked the board for around $530,000 for the construction component of this bid. It actually came in at $417,000, so we did very well this time. The apparent low bidder is BK Powell, who's also the company that's working at the Radio Hill right now. So it's a contractor that we know and we work well with. So I'm asking for the board by motion to accept the apparent low bidder, which is BK Powell. But in addition to that, we have identified additional costs for the project, which are things like cabling and computers and artwork and furniture and equipment that bring the entire project cost to $535,000.
That's
So-
for 1 and 2.
No.
Oh, it's for the entire
Right.
project.
So as we look at these projects, we'll be talking about 2 different sets of costs. We will be bidding construction costs, and that includes demolition, walls, floors, carpet. But between construction costs and total project costs are all of the cabling, the telephone, the equipment, the furniture, all those things that go in once the contractors move in out, what it takes for us to actually operationalize the space. So the apparent low bid was $417,000, and that included some alternates. But so I'd like to have that apparent low bidder BK Powell accepted by motion, and then approve the total project of $535,000.
2 separate motions or one
I
that
think-
includes both?
You know, that there's a legal requirement to accept the apparent low bidder, so I'd like that to be
Okay.
nice and clear.
So moved.
Second.
Okay, so this is just to approve, to accept the apparent low bid for MAC Phase 1 build out. This apparent low bid of $417,900. Are there any additional questions, discussion about this? Hearing none, all those in favor of the motion to accept the apparent low bid, say aye. Aye. Okay, it's unanimous. So then we have a second issue here, and this is the difference between the construction cost and the project cost. So that would be, the project cost total would be $535,000.
Inclusive of construction.
Right, inclusive of construction. So there's the $117,000 difference. $117,100 difference. So how do people have questions about that? Do people need to hear more about the specifics about what will be included in that? Any questions or issues regarding that higher amount of $535,000?
I do have some chunk numbers.
Sure.
Yeah,
That would be good.
please.
Fiber connectivity to the building is anticipated to be about $33,000.
And I'm sorry to interrupt, Julie, but so this is stuff that would be done by us?
Yes.
Yes, okay. So,
So fiber, what's that?
It's owner provided.
Owner provided.
okay,
So
sorry.
that cabling includes internal cabling and then we also have to bring in utility.
Okay. So this is, so these costs are primarily materials, but also, I guess, does it include, do you,
It includes the labor.
the labor, so do we do it, I'm trying to think how to phrase this. Do you hire other people to do it, or is it people that you
We sub out directly to
you
the
sub out?
contractor.
Oh, okay. Okay.
So fiber, cabling, and what we call dots and drops. Just future reference.
Dots and
Dots and drops, telephones, computers, those little things on the wall that you need to be able to plug in. And the associated equipment, the telephones, security system, intrusion detection, and cameras, and then a moving company. So those are some of the big things. And then in addition to that, obviously, we have the equipment and furniture.
And much of this is happening simultaneously, according to that, right?
We have a team, and you know, Jack Schwartz is working with him. Ron, obviously. We have Morgan Anderson for materials, who has the palette ready to go, and how you pick what you need for your waiting rooms and exam rooms and things. And I think understanding that we're going to be doing this a few times, we've tried to put together a group of people that know.
A question, for example, some practices will be moving tentatively peds and women's health. Will there be a need to buy new equipment? Can we literally, for example, the lab stuff that's over in women's health or peds, or do we need to replace that with new equipment, or can we move what we have already?
So we've made it very clear that there is no expectation that everybody's getting everything new. So we will make assessments about what should and shouldn't be.
But we've already started making those assessments in women's health in terms of what can go over, and there's quite a bit they can go over. There's some items that are already put in, mounted on the wall that we might just mount in this other place, so we're not robbing one area, so then we're destroying one space that we.
Just for the record, we haven't decided on who's moving.
Well, I think women's health.
We haven't decided on that,
Yeah,
but we haven't decided.
Right, so that's the only one we've
Yeah,
assessed so
so
far.
we,
Yes, but everybody's eyeballing each other's equipment right now.
Okay.
So in addition to that, I would say that this is the space we've identified as kind of the incubator space. I don't think 2,100 square feet is going to be big enough for a women's health, but we need to get them moved now. So Morgan's really focused also on making everything interchangeable. So we want to be able to standardize our pallets and standardize our equipment and things as much as possible.
And so if this cost went over 535, you have to get
I
back
would
to
come
us.
back, and you will get a report at the end on how much you paid.
Okay. Any additional questions, need for information on this project cost of $535,000 inclusive of construction costs?
Based on the timeline here, by the time this timeline is complete, do we think that it'll be move-in ready, or will it be weeks or something?
Until we move in, right? We should be ordering furniture and equipment with this time, with this occupancy date in mind.
Well, see, that's what I meant about ordering furniture. So, for example, the chairs and the waiting room at women's health. New ones, same ones?
It will depend. This particular budget includes waiting room furniture and side chairs and things like that. That won't necessarily be true for every project that we work on. In this case, it will be. And this is a little different in that this is brand new square footage because it is our incubator space. It just happens to be occupied by women's health right now. So, but we're trying to be real stingy.
Frugal.
Frugal.
And so
Nice.
I would like to have, I know we had a very useful process, I believe it was last month, where we imagined the big picture, but I want to imagine what then might go in the space that's currently women's health, because we retain that space.
Yes.
So.
And I don't want to harp on this, but Michelle, I think, is going to share with you in the context of our strategies how the space plan or how the strategic facility plan addresses access, and that should drive a lot of how these decisions between access, partnering, sustainability, all of those. So,
Would you say we're going to have a space team?
Space Force. We're calling it the Space Force.
Additional questions or requests for information on the 530?
Just a comment that all things considered, about $535,000 is a very reasonable figure. I'm impressed.
I hope subsequent numbers are lower though. We can hope, right?
We are going to get Space Force t-shirts into that budget.
All right. Any further questions about this project? Okay, then do I have a motion for the project to approve the project cost of $535,000, inclusive of the construction costs? Okay, motion. Seconded by Liana. Any further discussion or questions? Okay, hearing none. All those in favor of the $535,000 number, please say aye.
Aye.
Okay, unanimous.
So does it go in the record as not to exceed?
It's the budget, and so it not to exceed sort of the contracting terms.
Right. Okay.
I do, Carrie Youngblood has a number of updates.
I do. And I will be quick with them. I also have treats to hand out with said updates. So 3 things I just wanted to talk with you about really briefly. One is an update on where we are with the current collective bargaining agreement negotiations for the Teamsters RT group, and that's been handing out to you right now. We had hoped to have something here to be able to ratify, but unfortunately the Teamsters group has not had a chance to review it and bring it up for all. Has not had a chance to review the contract to be able to actually enact a vote with their group. But on the table, what we did get a chance to go over with that group, some of the key elements that we talked about and negotiated around was actually having a 4-year contract versus a 3. It also does cover all of our registered respiratory therapists. Some of the areas that are usually hot topics to talk about in negotiations that we actually didn't see any change on for this group is in our paid time off program that will stay intact from non-contract to their contracted status. Extended illness bank, same thing. There would be no change to that from where they currently are right now to where they've moved to under the contract. And at the bottom, I should have grouped it at the top, also their health insurance. They'd like to keep their current health insurance that they experience and enjoy right now as a non-contract employee into their contracted status as well. Where we did see some changes was in wages. We talked about actually applying a standard formula across the board. So instead of seeing an erratic percentage change from step to step or their annual increase, it would be a set number, which is actually 1.6% between each of those steps. We also talked about adding an additional 2 steps to the overall wage scale, seeing one in 2020 and the final one in 2021. The other area that we saw some movement on was in our premium pay. So that's our standby or our on-call, callback, they're calling on a regularly scheduled day off, weekend shift differentials. All of those experienced some increases, and we also put some in for future increases in 2021 as well, so they wouldn't stay static. The other area that we made some minor changes in that really was just in housekeeping was around the grievance process, actually including the employee, the supervisor, moving that over to the senior leader, then to the CEO, and finally to arbitration. So no action to be taken on that. Hopefully we will see something coming to the next board meeting.
Question, what's under premium pay, what's callback?
So if they leave shift and have to come back into work, there was some negotiation or conversation around how many hours would they be expected to be compensated for. It was previously 2 hours, and we actually extended that to 3 hours. So some good conversation on those things.
Okay.
Okay, thank you.
Thank you.
You're very welcome. Then to evaluations, I know that you guys have been very keen and wanting to know where we are as an organization with evaluations. I just wanted to call out that in April we were 86.5% complete. May we're at 92.8. As of today, we're actually at 96% complete, which is unbelievable.
Yeah, that's unbelievable.
It's really cool. We've seen the biggest increase of participation in our clinics. So really specifically, they worked very hard to get caught up, and they've had some new leadership in there that kind of blacks some things up, but they've worked really hard to get that caught up. So that's cool. The final piece I just wanted to bring up to you is just the transition of, saw the new signs at the coffee stand?
Yep.
Yeah.
I'm
So
sorry, would you say that again?
our signs down at the coffee stand, the coffee shop. So just an update in general about the gift shop and coffee stand conversion. We will be switching over to D&M, actually running the coffee stand as of July 1st. They are geared up, ready, and excited to do that. We kept intact the ability for employees to do payroll deduction. That was very important to all staff, and everybody maintained that. We are also looking to recruit a part-time gift shop coordinator who will handle all the purchasing, day-to-day operations in the gift shop. As soon as we have that recruitment in place, which we have some really good candidates we're looking at right now, we will go back to our standard operating hours of 9 to 5 and have that back open and staffed by our volunteer services. Any questions on any of that?
Nope.
Okay, thank you.
Thank you.
Mhm.
Anything else, Julie? Okay, thank you. Okay, Dr. O'Brien, we have files for review.
So files, yes.
There's a microphone there for you.
Yeah. Thank you. How's this? Is that better?
You sound like just like Sinatra.
I won't sing. My sister and I were the only two kicked off the church choir. Bad singing. Okay, the list you have, Nina Zosha is a geriatric nurse practitioner going to be joining us for initial appointment, has a clean record and is experienced. Liam Mansfield is a Yakima Valley radiology, a new hire there, a radiologist, has a good clean record. Andrew Thomas is going to be the other third initial appointment. Will be working in Clayle and family medicine, and as you may have noticed, we revised his application. He erroneously had basically applied for every special privilege, and as a new employee, he's required to apply for core privileges only, and then apply for any advanced practice as after he's been employed here.
Okay, so yeah, sorry to just interrupt there, but so there was one in there that had not been signed by members, by you and others. The one that has been signed, that's the one that would take effect. That replaces the other one.
That's right. I did sign the one a couple days ago.
Right. Yeah. The one you signed is the one that
is the one that's
that would be effective
to be in effect, which is applying for core privileges.
Right.
It's family medicine.
Yes. Okay. Does that, because I know a couple of board members had a question about that, does that answer our question?
Yeah, that's why I had not signed it initially, is because we had to have him revise his application and requests.
And so if we were to approve that one, it would just be approved as submitted because that's what's being submitted.
Exactly.
Okay. All right, thank you.
Thank you.
Sorry to interrupt, go ahead.
No, that's fine. Those are the initial appointments. The reappointments are Andy Schock, who everybody is familiar with, PA at Internal Medicine, is a clean record. Stuart Carden is a podiatrist who is applying for renewal of his associate privileges, even though his last actual work up here has been more than a couple of years ago. He did have one pending malpractice issue, but in reviewing it, it was an extremely minor thing where he just did a lesser procedure, and really no basis for any malpractice there. Other than that, his record is good. Cynthia Oberfelder is a direct radiology, remote radiology reader for us on evenings at times. has a clean record, reappointment. Stephen Johnson from the Yakima Valley Radiology, clean record, up for reappointment, and no change in privileges. And Kelly Noyes, of course, is our hospitalist, is up for reappointment and has no change in her request.
She's full-time hospitalist, correct?
Yes.
No longer does clinic work.
Correct.
Correct.
Okay. And we have two residents from Pacific Northwest Family Practice Residency Program, Christina Bowen and Sierra DeLay, with no negative issues in their resumes. Those are the requests for appointments and privileges, if you want to vote on that first. Then I will explain the additional privilege of dorm quorum.
Okay. I think the sort of one issue that some of us had has been addressed. Thank you for doing that. There was one other question I'm not sure I need to bring this into executive session. I think it might just be a typo that I want to just clarify.
There could be.
And so it's, I think, just in the, since this is really just typographical, I think. So lifetime board status, right?
Yeah.
If that's something we need to talk about in executive session, we can. I was just, I wanted to.
So most boards have gotten away from expiration dates. There's now what's called the maintenance of certification process.
Right. Yeah, and so we have a problem with that. That's what we're wondering about. Why is that no? Because it would seem to be yes, right?
Yeah, because he does have a certification date.
So if so, anyway, that was just something we wanted to clarify.
I suppose he was reading this as recertified.
I see. But he is, as far as both of you know, he has board status, lifetime date.
Yes, yes.
Okay, all right. Yeah, that's so, thank you. Yeah, so, so anyway, there was one file where the person had indicated that they were with a check mark, not board certified, but they are certified with lifetime for life. The no was just the person did not undergo recertification. It was a lifetime certification. And so they are certified under those. Does that help to clarify? Yeah. So yeah, those were the only two questions we had. So, any further questions for Dr. O'Brien? Does that help to clarify those? Yes. Okay. Then, hearing no further questions, do I have a motion to approve these credentialing files for initial appointments and reappointments?
I move that we approve the applications of the 3 initial appointments and the other reappointments, the residents. We didn't talk about the additional.
Yeah, that's going to be held off for a separate.
Yeah, I just want to explain what that is.
All right.
Right. So the initial appointments, the reappointments, and then the residents, we have a motion from Liana, second. Second. And a second from Roy. Any further questions or discussion? Okay. All those in favor of approving these people for initial appointment, reappointment, and these residents, please say aye. Aye. Okay, it's unanimous. Thank you, Dr. O'Brien. Now would you like to talk about?
Yeah, this is an interesting subject matter. This Laurel Dorm, nurse practitioner with Ellensburg Peds with Elise Herman, it requested to add a privilege of doing a frenotomy, lingual frenotomy on infants. I don't know if any of you know what that is. And it's actually an interesting subject. It's sort of a newer thinking about infants that have their tongue is not able to mobilize fully. And so when they try to nurse, they end up swallowing a lot more air. And then they end up being a colicky baby. Interesting new information and thought on this subject. It's a very simple thing. The tongue is sort of restricted from full motion by the band at the bottom of it and the midline being too tight. And it's a simple thing where you just put a little clamp on there and just snip it. And this allows more full motion of the tongue and more successful nursing. So And I actually researched it quite a bit because it's like, you know, is this a real thing or is this just kind of out in left field or something? And it's actually a real thing, and a lot of older practitioners don't do this or haven't done it in the past. But it's a real positive thing. It's so simple. It's basically a clamp on there and a little step with little scissors, and then the baby goes and starts nursing right away. That's the treatment.
So I have a question for you. I'm gathering from what you said that we don't have providers now who
Dr. Walters had been doing this and is experienced in it, and is would be the one that would be proctoring the nurse practitioner.
Okay.
In a number of cases, I think we
That's what it said.
we agreed on a number.
It's not, I did one 20 years ago. It's not a common procedure. It's becoming more common. The short frenulum, if you ever wonder where the expression tongue-tied came from.
It causes speech difficulties too. Yes.
And so 50 years ago, 60 years ago, it was fairly commonly done with no evidence to support it. During the 80s and 90s, given there was no evidence, the impetus was to stop cutting children. But now there's data that actually shows that children benefit from this if there is a short frenulum. And so it's, what was old is new again. But how many, the three came from trying to guesstimate how many times in a year in a fairly small community, given that it is a simple, low-risk procedure, how many times do we have to see it done before we're confident that she can do it?
So that leads me, I read publications that indicate that it's vastly underdiagnosed, perhaps because it's vastly underevaluated. Is that part of the standard newborn evaluation here, assessing for tongue-tied? Is that how would we
I couldn't tell you that, but I'm sure that
Isn't our lactation?
It's usually a lactation consultant with
where we've actually, I think
right.
kind of is how it was brought up, is Zika actually in helping moms breastfeeding, as when there's having challenges, they're thinking about this now. So.
And the one that I did long ago and far away was so obvious. I mean, when I did my initial newborn assessment, the frenulum was essentially, the tip of the tongue was almost, it was indented by the tension from the frenulum, and it was clear the kid wasn't going to be able to latch on. But yeah, again, as we've gotten more sensitive and started recognizing more, I expect it'll be more common, but how quickly that tide will turn, I don't know.
And I think we're just getting a new lactation specialist, aren't we?
We have one.
We've had one.
I can, Vicky's on vacation, but I will be happy to follow up and just make sure that we do know how to sort of do the assessment and add to that.
Does every baby have the benefit of a visit from a lactation consultant, or just some babies? I don't know how that works.
Actually, it's one of the quality measures that we track, but yeah, the lactation specialist is available to all of them. And how are we
I thought she was coming to speak actually for me.
Is she?
I think you asked for that.
Okay. Well, I remember asking for it. I didn't see it here, but that'd be great. It is a wonderful service. So. Yeah. And we are tracking.
Well, what's on the QI Council dashboard is babies that are exclusively breastfed in family birthing place. But she does have, Rosika has measures of, and so it's like any other service though, where people can refer to her. I think she does at least pop in on most of the inpatients when she's here.
It's just my hope that every baby will be screened for that. 'Cause I know many mothers are tempted to give up or do give up on breastfeeding because of frustrations experienced because of tongue-tied.
Because of poor feeding.
Poor latch, painful breasts
Yeah.
resulting from that.
I think it's just a question of how the screening takes place. It sounds like if the breastfeeding consultant goes in there and she's the one who notices it, there is training that goes on, it's just maybe not as, I guess, formal.
Well, and standard of care is that the newborn is placed at the breast, and if the kid latches on and does fine at 10 minutes of life, do we need, that's essentially passing the screening assessment.
Yeah.
Who evaluates the latch?
It's, well, given that, most births are at 4 in the morning, so it's probably the nurse that is at the bedside.
It's part
If
of a
there's
standard assessment as a nurse
Yeah.
and physician.
But, if there's a problem, then when day shift comes around, lactation consultant would be on the floor.
So we can raise this issue too with the lactation consultant.
It's not on your board calendar this time, but it may pass it back to the top
So just to come back to this issue, Dr. O'Brien, you're saying it's a simple procedure. You think that she's qualified to do it. She would be overseen by Dr. Walters.
Walters, right. We're doing a few, I think 3.
And so, are there any concerns or questions about this approval of this additional privilege? Okay. Hearing none, then we assume we have to vote on it. So, would anyone like to make a motion? Okay, we have a motion to approve this additional privilege. Second. Second from Roy. Any further discussion or questions? All right. Hearing none, all those in favor of this additional privilege, please say aye.
Aye.
That's unanimous. Thank you very much, Dr.
Thank you.
I have a quick question for Dr. O'Brien.
Sure.
I noticed that in the board calendar, the NEC meetings are scheduled at 5:30. Is that
5:15. 5:15.
Okay, 5:15. Could we get the correction in the board calendar? It says 5:30 here under NEC meetings, and I thought it was 5:15.
Shane, can you and I go to work on the calendar?
Yes, I'm quite certain it's 5:15.
Yeah, that was the time we felt.
To 6:45.
Thank you.
And yeah, Bob was at NEC meeting too. We're doing probably the suggestions that you guys have brought forward about everybody reviewing every chapter,
I
including Bob.
missed that meeting, but I showed up the next week at 5:15. No one was there.
Why weren't you there?
Yeah. No, your
I
calendar.
just got it wrong in my calendar.
I hate those calendars. I only get notices after meetings are done. Like, you missed this meeting. I mean, even if I was there.
Okay. Any further questions, Dr. O'Brien? All right. Thank you.
Thank you.
All right. Next up, Chief Medical Officer Dr. Martin.
So, with what I understood to be the intent early on, the only thing that I really want to call out in this report is the work that's been done with the Kittitas County Health Network, which may or may not morph into the Kittitas County Health Improvement Network. This was a group that was the product of the $100,000 HRSA planning grant for a rural health network that was the result of the grant writer the KVH funded to assist in partnerships and coordination of care in the community. That planning grant runs out on the 30th, and with that, Julie will step down as chair of the steering committee. She will continue on the steering committee. I'm on the steering committee. I was informed that I am on the steering committee for as long as she is, if not longer. I'm also on the leadership council working with the A team and on the IT subcommittee. If you remember the umbrella diagram that Amy put up with the CHOT-CHIP work group as being one tassel on the umbrella, the care coordination work group, which is essentially the A team at this point, is another tassel on the umbrella. And I want to call that out just because earlier this week there was a retreat of the leadership where the partner organizations recommitted to continuing that partnership and that cooperation going forward past the expiration of the planning grant. We continue to support that, and you can expect to hear more of it. But the feedback that I would bring to the board is the recognition from the group of our partnership and our leadership in that organization.
Yeah.
Other than that, I'd open any questions.
Great, thank you.
Well, I just want to express my appreciation to you for your leadership in the area of elder care and aging in place. Those are very, very important services. Coming out of the Chelan meeting, heard quite a bit about the concept of aging in place, and with the baby boomers now reaching the point where they start to worry about their mortality. This is encouraging. So I might even like to talk with you a little bit outside the board context about what work you're doing.
Thank you.
But I'm very appreciative of it.
One of the things that's driving a lot of innovation in long-term care is the recognition that baby boomers are not interested in the care that's been provided their parents. Bingo may have been good enough for mom, but it's not good enough for me. And that's actually a lot of the impetus behind some of the newer models that are coming out, including things like Green Care Farms, Greenhouse Project, and some of the other newer models of care. The Reader's Digest version of the talk I gave is that buildings like Prestige will probably not be competitive within 10 years, just because there are newer, better models of care. And what was the best we could think of in the 60s probably isn't the best we can think of now.
Would it be possible to schedule Dr. Martin to give a presentation to the board on, like what he did before the retirees? I'm really interested in these models of care, and as a baby boomer, it's very important to me personally, and exactly right. What my mother experienced is not the world that I envisioned. So let's get him on the schedule.
I think we need to take a vote on that once we get Bob here. Someone else who's not of retirement age.
The arrogance of youth.
So pending board approval.
All right, I guess we can listen to that.
I would love to.
All right, I'll probably get older. All right, so
one of the things I've learned is, as best I can tell, getting older beats the alternative, but those who really know aren't talking.
Leave my black humor. All right, so wound care is it's moving as scheduled.
The one potential hiccup there has been the Cerner issue. Cerner somehow, despite knowing that we had retained a consultant and hired a provider, didn't realize that we really intended to go live with this. We had failed to ask for a scoping call, a phrase that none of us had heard or a need that none of us knew existed. So we are scrambling right now. My expectation is that we will still be able to support the go live date. We may not have the perfect documentation and Cerner in place at that point, but there's going to be a lot of work on that in the coming days.
I'm glad that dermatology is up and running. There seems to be a big demand for that in the community. I've actually heard from community members about wound care
and it's one of, and we've got, it's one of the things that we have to get right. And one of the nuances of it is that CMS has really tightened documentation requirements in order to get paid. And there are tools out there that we can use, but we need to figure out how it's going to fold into Cerner. And as I say, we apparently got their attention about 2 weeks ago, and they realized that they needed to support this.
Well, thank you for working on it. Any other questions for Dr. Martin? All right, thank you. Okay, next up, CFO.
Okay. And I have a whole lot of things I need to talk to you about and ask you for. Sorry, Leona.
Is that okay?
Yeah. Okay. So,
since I was involved in constructing all those things,
yes,
I can't.
So a couple things I wanted to point out that I did not put in my write-up. But as you look at the statistics page, which is page 21, I would want to have you look at a couple of areas. I think I've talked the last couple of months since we went with CERN about wanting you to focus maybe more on year-to-date than monthly, just because there's a lot of movement back and forth as we work through the revenue and the charging. I think a couple of areas I'd like to point out. We didn't have 2,000 ED visits in the month of May 2041. There's some spillover from previous month of things that got coded and charged. And so they're reflected in May, but they're probably for an earlier time period. And then also, rehab was also a little behind, and it's getting caught up as well. So again, for the month for those areas, not inpatient services necessarily, but some of those areas, be sure and look at the year-to-date, because that's probably more accurate.
Right, so we should,
Yes.
you know, it's not about an 85% jump,
No,
40% jump.
no.
Yeah.
And I know there's been a lot of success with the daily revenue meeting that's being held, so a lot of this stuff is getting addressed and cleaned up, and as I understand it, there are fewer and fewer issues that are having to be reviewed and addressed at that meeting. However, when I was looking at this, it occurred to me that you really probably want to spend some attention looking at admissions, patient days compared to last year. I mean, we are up significantly. If you look at, we're up 12.5% on a year-to-date basis in admissions. We're up 19% in patient days. So, and that's not because of CERN. That's because our volume's up. So, I just thought it would be helpful to point that out. That's on line 1 and 2, and if you compare the year-to-date numbers.
When we look at admissions, the increase like that, are we believing that it's not necessarily people having no problems, but people who have problems more than are choosing to come here? Or do we not have that data teased out?
We don't. The other one I'd like to point out too, though, is rehab, because I think around this time last year, it was October. But if you look at this now, we're 11% above where we were in volume for rehab last year.
Yeah.
So that's, I think that tells a story that we need to feel good about that decision to make that change much more accessible.
Yeah, so that translates into people being seen, getting in sooner.
Yes, getting in sooner.
Yes. That's great.
Yes. So, so that I do write about my part in my comments. So, I also point out, I think I commented briefly about this, our AR days were at 80. Last month they were 83, so they were down 3 days, which is a good thing. I don't know what they will look like for the month of June, and I hope they continue to be lower, but I guess I would not be surprised if they pop up a little bit because we're still working through things. And as I had mentioned last month, I knew that our days cash on hand would pop back up because of the refinance of the MAC building. However, they're up a little bit more than we anticipated, which leads me into our cash discussion. So I love that at your place.
Are there any, any questions so far before we get to the?
Okay. We've done a really good job. We're bringing in a little more cash, I think, than we anticipated. From the CERN side, and again, I think as we've talked about, I think we're more accurate in our capturing charges, and we're billing and we're bringing cash in for those charges. So it's a good story, I think. And we have worked down our legacy systems, both Paragon and NextGen. I think that it's likely that sometime in July we will be wrapping up the engagements with those third parties who can doing that going for us. Any questions on that?
Any questions about this, Chuck? Okay.
So we didn't actually have a bona fide finance committee meeting. We had a nice finance committee. It was small. It was, and Roy and Julie and I, but it wasn't actually. Leon, do you want to talk about it at all?
Well, in as much as we were at Chelan during the time of the regular meeting was scheduled, we didn't have a quorum, but so rather than vote on items that we wanted to bring to the board, we by consensus agreed that we would bring them up. Okay, and I'll let you go ahead and itemize those. There's the prepay of the LTGO.
Right, you've got several resolutions.
Before we get to the,
yes.
sorry to interrupt.
No, it's fine.
Before we get to those resolutions, the days and accounts receivable.
Yes.
That, so you said you continue to identify and address remaining coding and billing issues. So you think that you're on top of that? It's going to start.
Well, we think so. It went down a few days in, it was 83, I think.
Yes,
April.
you go to, yeah.
Yeah, so now it's 80. I would like to say that it'll be lower than that, but to be honest with you, I did not check the original amount. I did not check to see where we were. And it's possible that it could pop up a little bit. But I know we're making great strides. I did, looking at that the chart that you're looking at where we're talking about the issues, I did validate with both the HIN director and billing folks that they felt comfortable with those goals still.
Okay.
That they thought that was a good representation. I think we're finding some of the things that we're finding they're not necessarily issues with Cerner. It's functionality that we may have had before, and in this one particular case that I'm speaking of, it's functionality that actually kind of allowed us to be a little sloppy on the front end in registration because there was something in the system that would kick errors back to be corrected before they were finally billed. Well, Cerner doesn't have that, but maybe what that means is we need to do something up front to make sure the registration is correct. You know,
Okay.
rather than allowing that defect in
Right.
the
Okay.
flow through the system. So anyway.
But that's being addressed.
Pardon, they
That's
are being addressed, yes, they're being addressed.
Okay.
No problem, so.
So did you want to talk about the resolutions?
Yes.
Any questions before we move on to them? Okay.
So the first resolution, the 1805, the debt resolution, that's a resolution regarding the refunding of the LTGO that's out there right now. It's my refunding, we're prepaying something to the initial lender, who I believe was U.S. Bank. And we have a couple of reasons that we wanted to do this. First of all, it does make some sense to consolidate with a lender that we have now who we've been able to borrow the $13.5 million last year, and we also did the refinance of the MAC building with them. They have a much more favorable debt service coverage requirement for us and days cash on hand requirement for us, which I think is important to kind of get them all on the same, so that the requirement, we have similar requirements across the board. The other thing that I think that's just very recent is with this PEB issue that's arisen with the reporting requirement. BBVA Compass Bank has been willing to write their paper so that they will exclude that liability from and the expense from the calculations, which is huge for us, which means that we would be able to be in compliance. And they're willing to do it on this new debt and also retroactively adjust the others as well.
So the idea is that you're borrowing from our current lender to pay off this older
yes
bond, and that because it'll give us more favorable rates and it'll help us to consolidate.
The rates might be a little bit more favorable. It's mostly the covenants which are important to us to have uniform covenants. In particular, knowing that I think it was important to us, knowing that we went to Cerner, we didn't want to be restricted like for days cash on hand, et cetera. And also moving into the world of value-based purchasing and new reimbursement, we want to have covenants that are more favorable to us, and those are.
So we're basically just moving it from U.S. Bank to Compass.
Yes, we are, basically. There are some costs associated with them, but we think that it's well worth it. So.
I have a question for you on page 31, and I would love for this to be accurate, but it does help me for this. Section 2, debt capacity. The valuation of taxable property within the district is $3,885,000,000. Is it really $3 billion? Oh, I'm sorry. I thought you meant for our taxable, those that we can tax.
This is, so the value of all the real estate that or property that is taxed
district, hospital district property?
No.
Or district land that we can,
Our mill rate would apply to a building.
okay,
Yes,
okay, all right.
yes.
Thank you. Okay, that makes more sense.
It's a
I
big
thought
number
this-
though, isn't it?
Yeah, I thought it
Yeah.
was saying that, that our district property, like hospital.
Oh, that we own?
Yes.
No,
and I
no,
was
no, it's
thinking-
the
I think
property
that's
in
what's
our
the wrong
taxing
spot.
district.
That's why she thought it was my fault.
Yeah.
I was so
She's
confused.
not that.
Okay, that makes so much more sense. Thank
Yes.
you for clarifying.
Yes, you're welcome.
Dale, you have a question?
I want to move the board's approval of the resolution. What's the number of it?
1805.
1805. The prepay of the 2009 LTGA loan.
All right, so we have a motion, second from Roy. Any further discussion or questions?
So the net difference in how this affects our bottom line, is it negligible?
Well, our cost of issuance are about 64,000, and then we also have a redemption premium, which we have like a prepayment sort of
For
penalty
the one we.
of, I think, 80, but over the life, it's worth it.
Okay.
It's a small price.
Like 80 to 80,000?
Yes,
So the cost then would be 80,000 plus 64,000?
yes, so it's about 144,000. Yes.
Any additional questions or discussion?
Do we have a second?
Yes, Roy seconded. Any further questions? All right, so it's been moved and seconded. So let's take a vote. Resolution number 1805, debt resolution. All those in favor say aye.
Aye.
Unanimous. Thank you.
Thank you very much.
1806.
Okay, so this has to do with the operating board interlocal agreements.
Okay,
For
so,
the,
yes.
one more acronym that's.
Yeah, sorry. Okay, so
1806.
So that one is, as I think you are aware, we recently joined the Washington Rural Health Collaborative. And there's a subset of that, the Washington Rural Health Collaborative Public Hospital District Group. There are a number of public hospital districts that are in the Washington Rural Health Care Collaborative. And one of the benefits of being part of that collaborative is that they're able to do joint contracting. So for example, they have a joint contract with LabCorp, which is at a more favorable rate for services than what our contract is individually. So in order for us to participate in that joint contracting, we need to have the board approve an interlocal agreement that allows us to be part of a group, contracting group. So for those services, et cetera.
Does this remove our privilege to choose if we weren't happy, say, platform to go with a different, even if the rest of the group is going to?
Absolutely. We don't have to participate in any of it, but this allows us to participate in the ones that we choose to participate in.
So it doesn't require us.
It does not require us.
They also negotiate pay to labels against premier or ISO.
Which would be helpful.
And this is a new opportunity, is that?
Well, we recently joined the Washington Rural Healthcare Collaborative, and that, from joining them, that's what brings us on to move forward.
I move approval of resolution 1806.
Okay,
Interlocal agreement.
all right, moved by Leona, second.
Second.
All right, Roy. Second by Roy.
That's okay, I just had another question.
Well, go ahead.
These other districts that are with signatures here, are they already within the collaborative, or is this a grassroots, we're all forming this newly together?
No, Collaborative's been around for a while, as the public hospital district, yes.
So say, Grays Harbor County and Mason County, they're already.
Yes, they're already in it.
Participating and enjoying the benefits.
Yes, and there are some recent new members in the
All right, so it's been moved and seconded. Any further questions? Discussion? All right, hearing none. Resolution number 1806, the operating board interlocal agreement. All those in favor, please say aye. Aye. Unanimous, thank you. We're going to have some more disagreement.
Why were we not in it previously?
Why were we not in it previously? Why would we not in it previously?
I had previous experience with my father through EMH
But we weren't in it. They actually reached out to us last fall to ask us if we were interested in joining. So, yes, we were invited. Yes.
Okay, thank you.
So
now-
I believe that the KDH medical office building motion has already been approved, isn't that correct?
Yes.
So that was the next item.
Well,
They only have some capital.
yeah, we have the capital
Right.
expenditure
Right.
request. So, do you want to talk about the anesthesia machines? That's 74.
Well, okay, the anesthesia machines were partially purchased through the $59,000 fund of need donation that came from the foundation.
Yeah, right.
So what we would be paying for would be the difference between that and the actual cost of $97,000.
And I just got the update from Lauren this afternoon. We actually got from Fund and Need, we got $34,545. So the event itself raised more than that. Those funds will probably end up being distributed to us through our regular distribution, but the actual Fund and Need pledges were $34,545.
So the difference is then $97,000 minus $34,500.
Yes.
Now that is considerably lower, am I not correct, than Fund and Need has raised in recent years?
I think it's lower than the
It was
last couple of years.
58,000 something last
Yeah.
year. Was it 58,000? Isn't that correct?
The high, no, I think it was 55.
55.
Last year, which was still on the higher side. They're generally right around the $40,000 mark.
So I just remember that it's been more than 40,000. I mean, it's been in the 50s at least.
The last two were good, and there was a significant, also, with digital mammography, there was the $15,000 contribution from the auxiliary. But if you look over the entire history of it, it generally averages right around 40.
Okay, and do we know why there was such a notable drop this year?
When the speculation, when the event was changed from the magical evening to the gala, and then they added the auction and things like that, what you're seeing is the bottom line for the event, what they're bringing in as a net is increasing, but it's being distributed through the auction and the silent auction and the games.
Not Fund and Need.
Not the Fund and Need. So the way that the foundation has the event set up, there's two pools of the event. There's the Fund and Need that is a direct dollar for dollar goes to the Fund and Need item. And then there's the ancillary between ticket revenue and auction and things like that that goes to the bottom line net. That bottom line net goes into the foundation's unrestricted funds, which comes through based on formula at the end of the year through distribution.
Okay, I see that. Well, I hope we don't go back to magic evening, even if it did run tomorrow.
I like that.
I can convey that to Lauren.
You might have it as a new board member, but you have to do it like 15 years in a row. I would love it every time.
Okay.
Okay, well, anyway, so, I forget, do we vote on these separately then?
Yeah.
Yeah, okay.
So I move the purchase of the two anesthesia machines.
And the cost is actually?
Well, you have to approve the 97,000.
Oh, yeah.
Even though part of the funding comes from the foundation.
All right, but the budget that's going to be spent now in the foundation is not 83 then?
No, it's 97,000. The actual cost is 97,000. So I would need you to authorize that, knowing that, and then you know that.
Yeah, we can authorize that. I was just trying to get clear on what the budget number was.
It was 83,942.
Okay, I thought that had been adjusted. I
The
thought
budget-
that, so what are we talking about? The 34 is not, that's the two pools, so it's just the,
The budget is what was put in the capital
Yeah.
planning document last year.
Underestimated
Yes.
the actual cost.
And then when it was selected as a funding need,
yeah.
the foundation raised 34,000 initially towards that 83, but the actual cost when Morgan went out to get the cost of it, it was 97.
Oh, okay.
Okay.
Uh, Did we have, okay, Liana made the motion, seconded by Erica. Any further questions or discussion? Okay, hearing none, all those in favor say aye.
Aye.
Unanimous again.
The second one is the imaging services, and we have money to, it wasn't initially budgeted, but we, of course, because of the money that we recently borrowed for, among other things, capital investments, we have the money. But my understanding is that we have to buy 2 digital arm systems. They have to be bought together. If we have to replace one of them down the road, we can replace one. But if we move, right now, moving these imaging services to digital has to be done together. So we have to buy 2 mobile arms.
Right, because they work together. Because the current technology that we have right now, we need to upgrade the whole technology. So that we've got, because one of them, there are 2 different mobile C-arm units. One that's used for larger appendages, correct? And then one's used for hands and things like that. But they have to be on the same technological platform. Is that the right thing to say? Okay. And that is digital now. And we actually have to move our imaging to digital anyway because CMS is required. So that's why it's a larger expenditure now. And the point is in the future, then if one of the units went down and we need to replace it, we don't have to buy 2 again. It's just we need to move the whole system to the same platform.
The budget indicates that it was initially planned that the item would be leased.
Yes.
Why did we step away from that and decide to purchase?
Because we evaluated how much we have leased up to date. The fact that we have the additional borrowing that we did, we need to maintain our balance sheet at a certain level. The things that we lease, there will be a change in accounting reporting requirements that will require that anything that's leased will be treated as debt in the future. When we were initially doing this leasing, that was not quite as eminent. We knew that eventually it could come. So we made the decision, particularly since we now have funds available because we borrowed the $13.1 million, that it made sense to stop leasing and start purchasing. The other thing is the leasing, we really wanted to lease those units that were likely to change quite quickly because of technology. Because you don't want to have purchased something and then, all of a sudden it's a dinosaur, but if you spent a lot of money for it, you're not so inclined to want to replace it, after 5 years. So I don't think that we'll actually be doing much more in the leasing arena going forward. Because it's always a matter of sort of balancing where your balance sheet is and make sure that you're using the resources wisely.
All right, so any further questions? All right, do I have a motion to approve
Motion already made.
2 arms? Oh, you made it already.
Yeah.
Okay, yeah, 2 arms. And you seconded? Erica took the second. All right, hearing no further discussion, then all those in favor of this capital expenditure request for the digital CRM system, please say aye.
Aye.
Aye. Unanimous.
Just a quick comment. I think the question Erica raised about leasing versus purchase is a good question, but I really think the answer is very good. First of all, the liability changes and doesn't reflect well on our balance sheet, but I think the point about technology and items where the technological changes are rapid, it made sense in the past to lease because we could then end the lease and move on and lease something new, but we're now where this is the newest technology and it will sustain itself for quite a long time. So I think those are my decisions.
And then I was handed this note by my boss to mention to you something related to an activity up in Upper County. I don't know if you're aware, some of you probably are, that on an annual basis the Kiwanis sponsors something called the Runner Stumbles Marathon. Right?
It's
not-
not
It's
It's not a
a
very
10K, sorry. Okay, a 10K up there. It's really a pretty setting. It's in Boston, in Suncadia, and it's coming up on July 8th. So just a shout out if you'd be interested in attending that.
How long is it?
There's a family
There's
3K.
yeah, there's a kid one, there's a 5K. It's really pretty setting.
It's near and dear to hospital districts.
Very much so. Yeah.
Okay.
Yeah. Thank you.
Anything else?
That is it.
All right, thank you. Okay.
You reminded me of one more thing.
Yeah, sure.
We recently, I think we talked to you several times about accountable care organizations. We've been aware of them, and I think you knew we were evaluating whether or not to join one, and made the decision to join one, and join the Caravan ACO, which is made up of their participants, not just in Washington State, but in various states, and it's been in existence for a number of years. It's been successful. There is no downside for KDH for the next 6 years, which is very important. There's an upside though for those 6 years. After 6 years, there probably would be a downside.
The upside
guaranteed that we could. The upside being that we get to participate in shared savings.
Yeah.
So.
Okay.
Right. So.
How long is the duration of our membership?
It's 3 years. However, we are able to extricate ourselves if we want to. After, I think you can only do it once a year. But
Exit period.
yes.
I mean, that's kind of a big deal. I'm surprised that posted don't have to.
Yeah.
But that's kind of a big deal.
I think we signed them today.
Oh, okay. All right. Oh, that's good. We've been talking about that for a while.
Yeah, it is really exciting though, because we think there are a lot of resources in there to help us move to our new care.
Patient centered medical home,
Right.
a lot of resources.
So we have guidelines.
And I think quality reporting, it's exciting because some of those metrics we need to report for what used to be called meaningful use, I guess. MIPS, right? We won't have to report those individually. We'll be reporting them as part of that group, which has been much more successful. That means that we're able to partner with others and benefit from their strengths. They're able to benefit from our strengths. It is a bigger deal, and we should talk about it more. So.
Yeah, do you think, I mean, this doesn't have to be for the next board meeting, it could be just something between board meetings, but just what you just said, like just put it out in a couple of bullet points about what
I'd be happy to summarize. Yeah, we're excited. Carrie and Mandy and I have been meeting several times, I think, to talk about what it looked like. Because we had to decide and sign up by the end of June, and we've been looking at it over the last several months, I think. And they've been reaching out to try to recruit us for a little while. We've had other opportunities over the last couple of years to join similar sort of things, and I think we really didn't feel like we were ready to do it. But we're at the point now where I think we are ready to join something like this, particularly when there's no downside risk for 6 years, because we've got a lot to learn and a lot of things to put in place, which I think some of the earlier contracts that we looked at would not have been good for us. But this I think will be incredibly beneficial.
That sounds great, yeah.
Newspaper.
We'll ask Michelle.
Michelle's spare time.
I think that would be great if you could just put together just nothing huge, but just a little, one paragraph primer on it.
Yeah. One more point about it, just that's kind of exciting, I thought, is their medical director is geriatric specialist, and we really want to get Dr. Martin in conversation. I was kind of excited when I heard that, because our chief medical officer has a huge interest in that. In fact, supervises our geriatric nurse practitioner program. So that's exciting. The other thing that makes us good timing-wise in here too is Dr. Martin has experience working in the ACO environment, and that's huge. That is huge.
Great.
It's difficult if your chief medical officer hasn't had that experience. I think it makes it more difficult.
Well, that's exciting.
Yeah, it is exciting.
All right, well, I look forward to hearing a little bit more about this. Thank you.
Sometime it would probably be useful. Sometime it would probably be useful to go over certain basics? What's the difference between an ACH and an ACO? Those are different things, but they're related. And I was listening to people talk at the Chelan conference about what their ACH was doing, and I thought it was their ACO. So one's accountable, and one is affordable, and one is community, and one is care. And anyway.
I like the Venn diagram. I'm still arguing for a Venn diagram. Let's see how all these things. Yeah. Oh, no. That's really concerning if it really is this.
Aside from the fact that they're both essentially creations of the Affordable Care Act, just to throw another AC in.
Yeah.
Right.
But accountable communities of health and accountable care organizations are two very, very different things.
When I talked Venn diagram, I wasn't thinking of those two, but there are a whole lot of things out there that are related.
But although I think that's what I think makes this so exciting is the ACH is talking about transitions of care and care models and patient-centered medical home, and so is the ACO. So, and it also aligns with our strategic plan. So to me, it's just like, what a great opportunity and timing for us, because it's kind of synchronizing. So even though they're separate organizations.
Sounds great. Well, I look forward to hearing about that. Great, thank you. Anything else?
I'm done.
Any other post-it notes or anything?
Any other post-it notes?
Okay, good. Okay, thank you. All right, now in operations, I don't see Vicki. Is someone sitting in for Vicki?
Vicki is on vacation. I think she's due back on Monday.
Okay.
So I don't.
Any questions or anything about Vicki's report before
Can we
we?
get page numbers for the reports?
76?
No, 70.
76?
Thank you.
Yep. So any discussion items or anything about Vicki's report before we move on?
No.
Okay, sorry, I just want to make sure you're.
I'd speak up.
Okay. All right, so Rhonda Holden, Ancillary Service.
All right, well, looking at 55 pages that she just shared with you in her reports and packets, so I have several paragraphs, right?
Manuals and stuff.
That's Brad Bird. That's not me. That's Brad Bird.
All right. Just a couple of things that I would like to add. First of all is recognizing some of our staff, one of which is Kim Williams in our imaging department. She just got her certification in ECHO, so that was a huge accomplishment for her and her study on her own, and we're really proud of her for getting that certification. The second is Ryder DeFranco over at Home Health and Hospice. She just obtained a license in independent counseling for social work. And that's required for working in home health and hospice. It's one of the regulations. But she was an MSW prepared social worker, and she had to do a lot of work for a year and had a mentor who was an LICSW. And so she did just sit for her exam and she passed that as well. So it's huge accomplishments for our staff. I'd like to share. And then what else do I have for you? That's not in your paragraphs there. Just quickly, some updates on what's happening in Upper County. This fits very nicely with what the health department talked about, probably part of the action plan that they're doing for community health assessment. Beginning July 11th and every Wednesday from 2 to 4, they will have a clinic up in Upper County, and it's parked behind Family Medicine Center by Medic 1. They've actually had permission from Hospital District 2 to be able to park their mobile van there. Although it won't be mobile, it's parked there, and they'll be having a clinic. So you're aware.
What kind of services are
they have a lot of different things. They're going to sign people up for health insurance, so I think that that's really fantastic. And they'll, have a nurse available to talk to. They'll do some vaccines, HIV and STD testing, hepatitis C tests, syringe exchange, referrals for other services. So there's a lot that they're doing. It's pretty exciting for Upper County. The second thing that I put at your table today when you came in was a letter that's been actually all over Facebook, but it's from Fire District 7, And they just have sent this out letting people know about the changes that are happening in their fire district. And they are actually changing their contract. They've given a 90-day notice to their fire chief and the assistant fire chiefs, and they will be doing a reorganization. And I think this is probably planning on having to go out for some sort of a ballot vote to be able to fund their program. They received a grant for their professional firefighters. So in order to sustain that model, they're going to have a ballot initiative. So they're already looking at preemptive changes related to that. And their plan is to hire a full-time fire chief and one part-time assistant fire chief on an interim basis until they know the outcome of any election. So that was just to give you an update as to what's happening up there, and we're certainly keeping an eye on it, trying to support them as much as we can.
And they are, in addition to medical and ALS service up there, these professional firefighters as well. So there's still a lot of overlap between the medical and these guys. So a little bit of shake up.
Yeah, I think it was, and there was a story.
Could you provide a little more context for where we are with the physical therapy and PLM?
All right, at this point, we hadn't been able to come to terms with the contract for the owner of the independent practice up there, and so we are just sort of letting things settle out. At this point, we're keeping physical therapy at Family Medicine Clayellum until we have any other sort of a transition plan.
Is it possible to ask what the issues were? I thought that we were kind of coming together, or maybe it's not. What his issues were.
I think he was anticipating to receive a lot more money for his practice than what we were willing to give. And that's really hard whenever you have a private practice for sale. I think everyone always thinks the value is really high, whether it's a physician practice or any other practice. And we can't purchase goodwill. And I think that had a lot probably to do with the purchase price.
Okay, that makes sense.
Can you remind me, going back to the echocardiogram, what the situation was prior to, now we have 5 days a week coverage for echoes and stress echoes. What was the situation prior?
I believe 2 days a week, is that correct, with Kim? We had had an echo tech move out of our community, so she was a part-time echo tech for us, and she left, and we hadn't been able to replace her. So now we have brought in our retired echo tech, who did a fabulous job for us. He came back, and he's actually training one of our ultrasound techs to be an echo tech. So we now have 5 day a week coverage for that. So we're really excited.
So I'm so grateful.
Nobody retires.
Yeah.
It's from California.
Yeah, they have a great staff down there, cross training.
Any additional questions? Comments for Ryan? All right, thank you very much. Next on the clinic operations, Gary Brown.
Yes, so the only thing I have to add in addition to the report is that most of you may know this, but Dr. Smith at KVH General Surgery, he conducts FAA flight physicals. So these are pilot physicals that are done. So the FAA actually came yesterday for a site visit when I was in Chelan. And they reviewed the 90 charts from last year, so we did 90 physicals, and out of those 90 charts, they only found 3 items in terms of documentation that would just be altered slightly, but it was all there. So, and then we have a 1-week window to actually return the form, and out of those 90 charts, 1 was returned 1 day late. So I think that was just really a great shout out to the service that he's providing there. And they did note that these need to be separate records and not put into Cerner. So there's a federal recommendation around that that we'll have to identify and address.
My husband is a pilot, and he's Mr. Smith and the doors in. And so 2 things. I'm glad that that they are that thorough, because that means that he really is giving, I didn't know Dr. Smith, but it's good to have that extra confidence there. And also my husband will attest that the FAA is so picky And so that's a really remarkable outcome of their visit, that they only found the 3 items, so that's awesome.
Yeah, so high five all the staff there and Dr. Smith. Doing great work.
Any other questions or discussion items about clinic operations? So dermatology is going strong.
Oh my gosh, yes.
And so, I mean, I think a couple of us were wondering how long we wait till we start trying to push it and increase that. Do we want to wait for a few months, see whether the...
Yeah, we're only booked out till the middle of June, so I would, and although that sounds
middle of
July. Oh my gosh, I just lost enough. But yeah, so I think that's great.
Yeah.
I'm erring on the side of caution of,
sure.
Is that just
yeah.
fantastic? There's a dermatologist, let me hurry up and get in.
Everybody.
Right, they flock to the new place. But, so I think it's still a little early to tell that our demand is.
Yeah, well, we saw it.
A trend.
I mean, as you know, we saw these numbers about the sort of demand for the community, just in general.
Right. Yeah.
Pretty good. There seems to be demand.
It's there.
But yeah, we'll see.
Yeah. I'll keep you posted.
Thank you. Other questions or? All right. Thank you very much, Jane.
Thank you.
Okay. So education and board reports, as you've all heard. Most of us were many of us went to the Chelan conference, the WISHA Rural Summer Conference. This was the Rural Hospital Leadership Conference. The title of this conference was Beyond the Walls and Into the Community. I took some notes there, which I'm going to assemble and send everybody once I give my editorials. I have to edit. But they talked about a lot of different things there. They talked about the opioid crisis, talked about state and federal sort of laws, what's on the horizon. Talked about various things, including how to put forward ballot measures and suggestions on that, how to sort of market things and how to present yourself. I mean, I learned a lot about various things that I hope to bring back here. I think mostly about organizing meetings and agendas and things, which we'll be talking about later or at another time. Do you guys have anything in particular you'd like to talk about?
Opioids, I think that's the one that stuck with me the most. And there were some figures. I don't think my jaw actually dropped, but mentally it did. And what struck me in those, the session was about people who become addicted or dependent, regardless of whether they started with prescription or started with extraneous use besides that. And I heard some people in the room murmur saying, well, we don't, thank goodness we don't have a problem in our town. Not quite like that, but that was the gist of it, that, just murmuring to their neighbor, we don't have that, thank goodness it doesn't affect us. And I know that it affects, I would be surprised if there's a single community it doesn't touch. And the time, in my opinion, is now to start making headway on it. And so I hope that that is a recurrent theme of our discussions and our efforts to do our part in taming that beast.
I know too that a lot of what we talked about was kind of getting upstream and dealing with a lot of the sort of social issues that lead to health problems. Leanna, in particular, I know that you were interested in the housing issue that came up. So that's something that we may want to talk about at another time.
Go
ahead.
One of the things that will be in my report next month is our involvement with ACH, which has been changing in the last week or so. But we will be a partner with them going forward. And the 5 areas that they hope to address, first and foremost, is social determinants of health. but also required project work is around the opioid crisis and initially practice transformation, transitions of care, and chronic disease management. But that's something that we will be expected to do more with the Medicaid population, at least with the recognition that what happens, what changes we make with the Medicaid population will quickly become payer agnostic.
And all of that has implications for how the design and projects we look at the space for designing.
Right. Yeah, Roy, anything to add?
No, I think the two issues with opioid and hospitals and the homeless, that was startling.
That was
Some of the data.
correlation between unsafe or insecure or homes or homelessness and medical situations, medical difficulties, visits to the ER are staggering.
So can I just comment? I sat through the governance one where some of the time was spent on strategic plan development and mission development, and I was sitting by Sarah Kay, the consultant who worked on that with us, but she was not the one doing the presentation. And your process hit it on absolutely every single point. I mean, I just saw it circling back to the community, how do you reach out to the stakeholders. I just think there's an enthusiasm for the strategy, for the vision, and it's a lot of it. It's really pleasing.
It's affirming to go to the sessions, to go to the sessions and hear them, like you said, ask us to consider doing what we've already been doing. It's pretty great.
Okay. Thank you guys for that. No old business, new business. Teamsters contracts is not here. We'll deal with that another time. Thank you for filling us in on that. Okay, so we'll move to the community relations report. Michelle Worrell.
Do you have, let's start, do you have any questions on the report that was submitted?
I love Walk with the Doc. I think was that your idea?
No, actually that started with Amy last fall. And so it was up in Cle Elum last fall, and then we brought it to both locations this year.
Well, I think it's a wonderful idea. I'm really excited. And also, Roy sent us an email about, and I don't know if it was under your purview, but the idea of music in the hospital and music in the some care facilities. And I'd like to, I'm not sure that would come under your bailiwick, but I'd like to see us pick up that idea and follow it up.
To elaborate, the type of music is not piped in, it's live.
No,
right?
live performances. And we, with Central here, and we have all the students. The idea of maybe taking advantage of that, I think that's wonderful.
We've done that a few times.
That's great.
There's live music of some sort or another at Prestige almost daily, and that's pretty typical for long-term care facilities. Because it's provided by volunteers, the quality can be variable.
Tim O'Brien and his sister.
The O'Brien duet.
But it is one of the times when I'm always grateful when it's a harpist, because you can drop a harp downstairs and it won't make a bad noise. As opposed to the things that can be done with, and to, a trumpet or a violin. But gospel sing-along is a regular feature at Prestige. That's usually once or twice a week. So that is recognized, but it's still only an hour or two a day.
Yeah. Okay. So we'll. I'd like to sign with an entrance sign.
Yeah,
anybody notice the new sign with the entrance?
That says,
all lanes open.
Exactly,
Yeah.
with our 4 strategies.
4 strategies.
When did that go up?
Yesterday.
Yeah, if you haven't noticed.
Was it the office?
Friday. Yes. Yes. So, one of the things that Julie asked me to talk about was the whole master site facility planning, and kind of backing up a little bit to how we got to where we are, and then how we're communicating and why we're doing what we're doing. So obviously there was some transition, so I was digging into things myself. And wanted to just kind of call your attention, it was back in 2015 when KVH kind of reinitiated the whole facility planning process. And on that, it wasn't just about space that we were talking about. We were talking about improving care process, consolidating the electronic health record, and space. We know what we've done with the Cerner implementation on the consolidation of the health records, improving care process. That work was done throughout 2015 and 16. A lot of good work was put in through that, and we still plan on taking that work forward in this new space that we're looking at. And back on March 7th of 2016, and this is what I handed out to you when you came in, the board actually put forth a motion during a special meeting saying for the construction of outpatient clinic buildings south of the hospital, we're talking about phase one, what this would be. It would be for the construction of an outpatient clinic building south of the hospital and would provide additional parking spaces. It was also noted that the plan would require vacating Spokane Street and demolishing the hospital-owned houses in that area. There were 2 subsequent motions that were approved adopting that concept. So then, fast forward, we go through to
I have an explanation for this.
It's not, no explanation necessary, but you're welcome to share.
There were some legal hurdles we weren't aware of at the time.
Absolutely, no, absolutely.
Other things.
But the reason I put that forward is because in conjunction with the 2018 strategic plan, as we all know, there's been a shift in the direction that we're going. And as we're purchasing the existing space and remodeling it to fit the needs, that ties directly into what we've talked about with our 4 strategies of access. We could not wait for the new building to be there. We wanted to meet the patients where they were, engage with the community, listen. Like you were saying, there were issues that people weren't aware of. We wanted to hear the feedback from the providers. Partnerships and collaborations with the existing clinical partners that are already there, pairing our clinics and specialty services with other collaborators. And financial sustainability. It was just using that existing space was a more economical decision to move forward. So there still is some ambiguity. We had put out some press releases in December when we made that final purchase of the MAC. There were some really good articles in the newspaper that called out the transition of plan. But I think it's important that since there was something officially on the books as a motion of the board, I would ask you to consider tonight that you might actually make a motion to officially rescind the affirmation motions from the March 7th, 2016. So there is no question about are we doing that or are we not doing that. We've sent direct communications at the time in December to the homeowners involved, but I think it would just be a nice closure.
So the vote would be to rescind these 2, the approval of the overall concept of the master facility plan and the initiation of phase 1 of the master facility.
Correct.
I think that's a very appropriate step, and I totally support Arlene, so.
Yeah, go ahead.
So in the instance that we decide that we do need to utilize that property, we have a new resolution for it. Is that helpful? So we just tidy up this one and leave that as a open plan piece. It's unassigned.
And I think that the way you related this, our new decision to the strategic plan makes a lot of sense.
Okay.
I like that.
Well, and the hope then tying in with the continuation of how are we going to push this information out and how are we going to really live our strategic plan and our mission, vision, values. You saw the sign that was out in front of the portico. We haven't done a newsletter recently, and there's been so many moving pieces that it's like by the time we put that newsletter out, the information was probably going to be false. And so not false, but updated. So my hope is that within the next month, to be able to take information like this, communicate that out in the newsletter, talk about dermatology, talk about pediatrics, when we have some of these things ironed out of exactly what's happening when, where.
When was the last newsletter?
Fall of 2017. Fall or winter, I think it was winter. So that right there is a good source of information to get that information out. Visuals are something that we are still very much working on within the system. One of the things that it kind of just breaks my heart is there are some things that we can do in the clinics, but one of the big things we want to do, for example, is get the digital displays up into the clinics. But we don't want to put in a lot of money on that right now with all the moves and relocations and things like that. One of the reasons we want to get that out is we want to meet our employees and our patients where they are and hear about how they're living these values or seeing these values every day in the workplace, and capture that both in film and in still image, and use that in the newspaper, use that on some of these digital displays. Because as you learned in Chelan, you know, we can put ads out all we want, but it's the face, it's the story, it's the people that they know. So that's one of our plans. We're still looking at things as far as flags in the lobby, but it's one of those things as a graphic. Jan and I have probably been through 4 or 5 drafts, and they're just not hitting yet. We know the concept, what we want it to look like, but it's just not feeling there yet. And we're trying to tie all of these into Morgan's color scheme. So no matter where we place it, whether it's here or in the map or whatever, we have some continuity.
Morgan's color scheme. Morgan is.
Yes.
It's not Morgan. My first one to school.
No, sorry. So Morgan and materials. So we are, you know, we're looking at the graphics when people walk through here. We're looking. I don't know if you noticed when you first came in on the internet. So that's that same concept as we're talking about the code of excellence with our employees, and that actually we kind of went through a nomination process and people were called out. So these are the types of things where we really want employees to live it and to feel it and kind of come to us and this is how we see it and be able to capture that.
Great. Any questions before we get to the motion things? Any questions? So let me just ask the rest of the people over there. Any questions or issues or comments regarding this strategy? All right. In that case. So let's start from the most recent. So the approval to initiate phase 1 of the master facility plan, the motion would be to rescind that vote of approval that initiate phase 1 of the master facility plan. So do I have a motion to rescind that approval?
I move that we rescind the approval of the motion to initiate phase 1 of the master facility plan made March 7th, 2016.
Motion by Leanna. Second?
I'll second that.
Seconded by Erica. Any further discussion? All right, so all those in favor of the motion to rescind this approval to initiate phase 1 of the master facility plan, please say aye.
Aye.
Aye. Okay, unanimous. All right, so then the second motion would be to rescind the approval of the overall concept of the master facility plan. Do I have a motion to rescind that?
So moved.
Okay. Motion from Liana, second from Erica. I think. Okay. Any further discussion? All right. So the motion is to rescind the approval of the overall concept of the master facility plan. All those in favor of rescinding that, please say aye.
Aye.
All right. Unanimous again. Thank you.
Thank you.
Any further?
Is there a way that we can get that out as a press release or something, or?
I think she's got it as part of this larger plan to tie in our building plans with the with the strategic plan.
Yes.
That's good.
Yes.
So that would be the idea.
And then the last thing, I just wanted to give you an update on our water safety plans. So we've been, as you know, we've been working with the city, and we've come to an agreement with, I just know her first name is Jody, who organizes this at the pool, that yes, KVH will cover level 1 water safety courses for the community. And the problem is that Ellensburg pool schedule started at the beginning of June and runs through August. So they're not wanting to start us sponsoring that until the fall schedule. So we're trying to say, is there any way that you would consider this? The response I got this afternoon was most of our classes are full already. And they are making it probably more difficult than it should be, but ultimately it's their call. So from what we gather, the latest we would be starting that would be this fall for the fall session, and it's something that we would continually do ongoing. And my understanding is that the courses are still full, but it's disappointing that we don't get the opportunity to do it this summer.
They have no capacity to add classes.
We are not getting that now.
Okay.
So there is, this is near and dear to my heart. I think the agricultural community for this innovation funds and I think it's a great initiative for the district. Training youngsters to that also.
And the university pool is not an option. I don't know if they do that sort of thing.
They
Or-
used to.
They run classes there.
But collaborating with us.
I will add that to the
Question, what are we doing in the farmer's market?
So
Do we just have a booth or?
So this year, yes, we have a booth. And the ER came to us, and they have some things that they are mandated to get out as far as different educations. They're looked at CPR and stock with lead, but that's based on availability of people to come. So based on their availability, they may partner with us. When they're not there, what we're doing is we're focusing on healthy eating habits. And Bree actually had a great sit down with Jim Gallagher, our new dietary manager, and he's all on board. He actually wants to go. Right now what we're doing is we advertise our Pinterest page, we talk about recipes and menus, we give them recipes, we give them handouts. That's what we're doing today. Jim just came on board, and Jim wants to actually bring a hot plate or something like that, and this is was the whole vision to begin with, is go around to the different vendors that are there, use some of the product that they have there, and do cooking displays. Bree's checking with the health department to make sure that we're doing this correctly. The other thing that we're doing
That came up in Chelan last year. I don't know if you remember.
we're reaching out to HD2 when we're up at the Roslyn markets to see if they would like to share space with us and have a presence there as well. So that's what we're doing. We had some Bree said this last weekend she was there, she had some pretty good success. We kind of gauge that, number one, by how many contacts, but then we also, those KVH cooler backpacks, we fill those with other nutritious items, or nutritional related items, and raffle that off so we kind of can judge by how many tickets, how many people are coming by. And she said it was pretty good in Ellensburg this last weekend. Roslyn's a little tougher nut to crack because it's a very, I call it like a transient market. There's locals that come in, but there's a lot of tourists that are just checking it out, walking it. And Bree said this last weekend she was even hearing from the other vendors. There were a lot of people, but not a lot of purchases. So we're always trying to what's going to engage somebody, what's going to get them here. But that's kind of our status right now.
Okay. Any other questions?
So going back to messaging about facilities, when are you thinking that the bulk of
The newsletter type thing?
the newsletter or just hitting various?
Yeah, well, so I think when Julie does her board summary of what happens here to the employees, I think that's one very good place where she can address this. And I want to be careful on how we don't want to get ahead of ourselves on the messaging either, since we're still trying to figure out pediatrics and where's that going to go and how. So I want to be able. So the answer to your question is I see the newsletter coming out. Hopefully, I put it on my calendar. We would develop it in July with the intent for it to go out in August.
So I think that's something that even says, hey, this is the new MAC, and we're really excited to be bringing you new services, and listen, keep your ears open for more to come.
I don't disagree with you. I'd like Julie and Richard to get some things finalized in that space before we go too far out there.
It's just an appetite.
No, I totally agree with you. Totally agree.
Anything else? All right, thank you, Michelle. Okay, so how long do you think we need an executive session? Nothing? No time?
Cancel.
All right, well, I think we were done this.
Yeah.
We just adjourn and eat?
Yeah.
Is that what? Okay. Well, then we don't need to go into executive session, so 7:55. Unless there's anything else, this meeting is adjourned. Are you going to get to use again?
Wow.
Yeah.